Okay, so we are now live. So I'll be starting the session.
Go ahead.
Okay, so uh, respected delegates and faculties, welcome to this live webinar of Corona Remedies. It is jointly associated with Foxy Endocrinology Committee, and also it is jointly associated, in the association with Kanchipuram, Madurai, Namakkal, Tanjavur, and Pondicherry Society. So I welcome you all respected delegates and faculties in this live webinar. The theme for today's session will be endocrinology of male infertility. So this will be the theme. And let's come together for the lamp lightning session for 2 minutes. Then we will start the session further. So thank you so much, all the respected delegates and faculties. And now I hand over the session to Dr. Chaitanya Ganguly, sir. He will take it further. So over to you, sir.
Thank you so much, Nilesh. I would like to welcome Dr. Rishikesh Pai, sir, Foxy President. He has just joined in. This is a Foxy Endocrinology Committee webinar on endocrinology of male infertility, and we are having societies from Kanchipuram, Madurai, Namakkal, Tanjavur, and Pondicherry with us today. I would also like to invite Dr. Sampath Kumari, Madam, West Zone Vice President for Foxy for this webinar. And I would like now Rakhi to start, Dr. Rakhi Singh, who is the chairperson for the Endocrinology Committee, to start with the proceedings and welcome our dignitaries. Over to you, Dr. Rakhi.
Thank you, Chaitanya. At the outset, I would like to bring you greetings from Foxy, President Foxy, Dr. Rishikesh Pai, sir, Secretary General of Foxy, Dr. Madhuri Patel, and the Vice President for Endocrine Committee is Dr. Gitendra Sharma. Greetings from him also. And we are fortunate enough for having President Foxy, Dr. Pai, sir, with us for the chief guest address. And we've got two vice presidents for our seminar today. That is Dr. Kitendra and Dr. Sampath Kumari to be there with us today. And can we have the formal CV of our President Foxy, please? Dr. Pai.
President Foxy bus ho gaya.
Dr. Pai, sir, as you all know, his multitasking personality, and he's taken Foxy to a greater heights than what we have seen. And he's a person who is there for masses and for the people. And he's done a lot of work in his tenure. And right now he's the medical director for Bloom IVF Group and administrator for the Foxy Manyata initiative, which is doing a lot of work on that front. And director in corporate affairs for IFFS, International Federation of Fertility Societies, adjunct assistant professor for the Eastern Virginia Medical School, USA, postgraduate teacher in gynecology at DNB examinations for India. And his area of interest is infertility endoscopy, which we have heard him at length all these while also. And major achievements, he's been awarded at many functions and awarded as an esteemed fellow and addendum for RCOG UK, and past Secretary General of Foxy. And he is a past president of ISAR, IAGE, MOGS, and MSR. And he is a celebrity doctor who has helped more than 20 Bollywood celebrities and their children. and awarded more than 50 awards and delivered many orations, an editor of more than 16 books and written more than 50 chapters, founder editor of Journal of Gynecological Endoscopic Surgeries, and editor of the Indian edition of British Journal of OB-GYN, and founder chairperson for the Indian SIG American Society of Reproductive Medicine, ASRM, and numerous research publications are there to his credit. Apart from this whole CV, he is the mastermind for starting GCPRs in association with the committee's chairpersons, and more than 30 GCPRs are going to come down from his tenure, and roughly around equal number of Foxy focuses, 30 Foxy focus during his tenure. There's a big list of work which he's doing with Badlav, and a lot more Badlav is there in the Foxy. Over to you, Paisa.
Thank you, Raki. First of all, I must congratulate you. Are a dynamic chairman. To your committee. I think must have got the prize. Otherwise, you should get it. You're one of the future vice presidents of the federation. All the chairmans are very good at.
Can we have the CV off, please? Can we have
all are fantastic chairs. All the chairmen, 28 chairmen.
Stop screen sharing.
This is what we. Can you hear me, Raki?
Yes, sir. Yes, sir.
This is what I, use the resource. So basically, rather than, every president gets their own 2-3 people to work, I said, this is our people. But who are our people? Our 5 vice presidents who are superb. Each one of them can become a president in itself. Dr. Sampath Kumari, Dr. Gitendra, Dr. Yashodhara, Dr. Alka Pandey, and who is Dr. Sampath, who is
Asha
Bakshi. So these 5 are superb, 28 chairs are excellent, and so many people are working for the federation. I tell everyone, someone says, sir, humko nahi bola, tum batao. See, it's very important to tell. We are very, very busy. We have to tell. Just now I have come from RCOG. I was called for the first time Foxy, not Dr. Pai. Dr. Pai for Foxy was called me, Dr. Rishma, Dr. Bhaskar went for the RCOG. First time after many years, they called us and they gave us a session. I was there, and then from there, direct flight I've taken and come to Vietnam. Just now I'm in Hanoi. You can see this is Hanoi. This is where the ACOG meeting is taking place. Just now I attended the meeting going down for the inauguration now. So the federation is very powerful. I would say that if not, we are as good as FIGO, but probably more also, because what happens is our country has a lot of developmental work. Now, 10 areas of developmental work are there, huge amount of public health, CSR, you name it. We don't have to even look beyond our borders. We have got so much work. And we have, looking at our year, Dr. Sampath Kumari and me and all of our vice presidents, we have already done 13 conferences, 11 more to go. It's the highest. I don't think anyone has done so many conferences, and all are well attended. So we have a very powerful resource that we are doing, and we have the foreign conferences. The UK, London is all full. We are now going to the Paris conference, and there's a IFFS conference in Greece also. So, and then we have these round tables, and you name it, and we are doing it. So I sometimes feel that I should have more time to do it, but as bad luck or luck would have it, we have only 1 year to do what. Fortunately, I got 3 months more. I got 14 months to do it because of the COVID, and after that I will continue. So basically, this is very important. The leadership is very important in an organization. Leadership has to continue. And the best way to continue leadership is to support the next leader. So the next leader, Dr. Jaideep Dang, I have to support him. I don't have to suddenly switch over and say, "Acha, mera bhi to ho gaya. Abhi I am going away." No, you have taken from the organization. You have to give back to the organization. You have to work for 10 more years. And this is very important advice I want to give all of you, that you have to work for 10 more years. I can see a lot of Chaitanya Ganpule, very dynamic person, has done a lot for endocrinology. Meenu Handa, again a very important pillar of Raki Singh's group of people. Dr. Chandra is there, and so many, Dr. Fahim. So there are a lot of people who are there. Dr. Hemlata. So we are all grateful to all of you for doing such fantastic work, and we are looking forward to big leadership from all of you in the future. We will to fade out, but the organization should continue, and you will be the next leader. So this is how life is, and we have to see that we support each other in a lifelong manner. Most important thing is fellowship. Remember that the most important is not academics, it is fellowship. If tomorrow there's a crisis in any one of our 40,000 members, we should be able to take care of that member. That is the most important role of associations. To take care of their fellow members is the priority role of the association. So thank you very much for calling me Rakhi, and wish you all the best. And also Chaitanya and Minu and all of you. And we are looking forward to Sampath Kumari's Kodaikanal conference. She is my vice president and fantastic vice president. Superb work, dedicated work.
Thank you, sir.
Where everything I tell her, she does it silently without any saying it, and excellent work. So I'm actually very happy. All my 5 vice presidents are superb. I'm very happy to have them. I'm very lucky also. It's all, I always say, ultimately life is luck by chance. Thank you very much.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you so much,
Thank
sir.
you. Okay,
Thank you.
bye-bye. I have to go
Bye.
down for the inauguration.
Yes, sir.
Thank you, sir, for
Yes,
taking
sir.
out
Bye,
your
sir.
valuable
Nice
time.
Thank you, sir.
Have a nice
Bye,
day.
bye,
Thank you, sir.
bye.
Can we have Dr. Sampath Kumari Madam's CV, please? Dr. Sampath Kumari Madam is Vice President of FOXY and Senate member of Tamil Nadu MGR Medical University, National Corresponding Editor and Journal of Obs-Gynae Society, that is JOGI, Founder Secretary of Tamil Nadu Federation of Obs-Gynae Society and retired Director Institute of Obs-Gynae MMC Chennai, President Board of Studies for Obs-Gynae Tamil Nadu, MGR Medical University, Chairperson of FOXY Adolescent Committee, and first ICOG Distinguished General Body Member Award in 21, and Chairperson for the Women's Wing IMA Chennai Southern, and IMA National President Award for IMA in Tamil Nadu Award in 21. Over to you, Sampath Kumari Madam, for your kind address.
Thank you, Dr. Rakhi, for the nice words. Respected our dynamic president, Dr. Rishikesh Pai, and our secretary, Dr. Madhuri Patel, Madam, and my co-colleague, Vice President, Dr. Jitendra Sharma, and Chairperson, Dr. Rakhi Singh, for organizing such a wonderful program with the convener, Dr. Chaitanya, doing the wonderful work. I think all the topics you have mentioned is that is endocrinology of male infertility, understanding the normal spermogram by Dr. Rakhi, and the recent update in the management of oligoasthenoteratosomia by Dr. Rahim, and the panel discussion by Dr. Chaitanya with the panelists and chairperson Dr. Chandra, Dr. Tamilmani, Dr. Lata, Dr. Gayatri, Hemalata, Uma Brinda, Kubra, Minu, and Nilesh. So the expert being Dr. Jitendra Sharma. I think you are covering all the topics of the male infertility. I wish all the success for the webinar, and all the best for Dr. Chaitanya. Thank you.
Thank you so much, madam.
Yeah, good evening, Dr.
Thank you,
Chaitanya.
madam.
Good evening, Chandra
Welcome,
madam. How are
Chandra.
you?
Good evening, Rakhi.
Welcome, Chandra Madam. Over to you, Chandra.
Thank you.
Thank you, Sampath Madam, for that kind words. And let's move on with our academic discussion for today. Let's start with our first session, and let me call upon Dr. Chakravarti and Dr. Jyoti Sundaram to chair the session. Dr. Chakravarti Madam is not well, so I think she's unable to join. So, Dr. Jyoti, are you there?
Chaitanya Chakravarti sir, A.R. Chakravarti
Yes,
sir.
sir.
He is a very senior person.
Okay, sir. Okay, madam. So he's not well, so he has conveyed his
Good evening.
regards that he won't be able to join. So, Dr. Jyoti, are you there?
I'm not able to see Jyoti's name also. You make Dr. Chandra itself.
Okay, so I would like Dr. Chandra to chair the session, and I would like her to introduce Dr. Rakhi Singh, who is going to speak on understanding normal spermogram. Over to you, madam.
Yeah, Rakhi's, good afternoon, everybody. It's a privilege for me to be part of this webinar. And I thank Dr. Chaitanya, Dr. Sampath, and all the others, and Dr. Rishikesh Pai for the opportunity given. Now, I'll introduce Dr. Raki. Raki is a dynamic person, as Dr. Pai said, and she is the chairperson of Endocrinology Committee and vice chairperson of UP State ISAR, and she's a peer reviewer for Journal of Obstetrics and Gynecology of India, Jogi, and she has got many awards, achievements, and publications. She is the invited faculty for 350 national and international conferences, Foxy DC Datta Award for publication in hepatitis B in women, and Foxy CS Dan Award at 65th AICOG First Prize. And she has written chapters in books Foxy Focus and Jeffcott Gynecology, Fibroids Management, ISAR Express, Dilemmas and IUI, and Yearbook of Obstetrics and GCPR. She has done so much academic as well as in the Foxy platform. And she's an Wonder Foxygen Award, DERA Award, ICOG Appreciation Award. Now she's going to talk upon the normal seminogram. Yeah, the toys is yours, Dr. Raki, please.
Thank you, Chandravati Madam, for the kind introduction. And at the outset, I would like to take the opportunity and welcome all the delegates from Kanchipuram, Madurai, Namakkal, Tanjavur, and Pondicherry Society for this endocrine committee webinar. And as it is, this is my hierarchy of endocrinology committee, which we have already heard of. And moving on ahead, today, my talk would be revolving around understanding the normal spermograms, which is at times a neglected topic, but it is very, very important for us to understand because implication has to be borne by both as a couple. And when we talk about the disease burden in the male infertility, approximately 15% of the couples of reproductive age group have fertility problems, and about half of these cases are because of the male factors. A male subfertility is a clinical disorder that accounts to almost 30% of the reproductive age group couple worldwide. It is none of the part of the world which is spared because of that. And according to the complexity, it is that men typically do not seek healthcare unless it is acute medical need or as a need in the case in the infertile couple where they have to go. Advanced paternal age is associated with increased risk of adverse perinatal outcome for both the offsprings and the mother. The lifestyle factors such as obesity, smoking impact not only the male fertility aspect, but also the offsprings as well. The various factors which are involved in the pathophysiology of the male infertility, which could be inclusive of oxidative stress factors also. There are various nomenclatures which are used in conjunction to the semen analysis. Oligospermia could be called because when the sperm count concentration is less than 15, sperm concentration is the total number of the sperms, which if they are less than 39 million, that is 10 to the power of 6. Or actinospermia is where the progressive motility is of the sperm is less. Motile sperms are less than 32%. Teratozoospermia, the morphology is affected and it would be less than 4% when compared to the normal spermatozoa. And oligoactinoteratospermia is termed where the disturbance is seen in all the three factors, that is morphology, progressive motility, and the sperm concentration. There we call it as oligoactinoteratozoospermia. Azoospermia is no spermatozoa in the ejaculate, or aspermia is no ejaculate if the person feels. And leucospermias are the leukocyte count if it is more than 1, and cryptozoospermia is a spermatozoa which are absent on the normal fresh preparation of the semen analysis, but they could be observed when the sample is centrifuged. And WHO parameters, what we follow nowadays is 2010 WHO semen analysis parameters, which we are following, and every center follows it, and the guidelines are fixed for that. And semen parameters, normal parameters, when we consider according to that, the motility has to be more than 42% or equal to 42%. Concentration of the sperm has to be more than 16 million per ml. Morphology is more than 4% of normal sperms. If we are seeing, then it is okay. The prevalence, when we compare to the different parts of the cities of India, the male infertility rate is seen high at Bangalore, Kolar, Jamnagar, and whereas it was a multicentric trial which revealed this. And a retrospective analysis was also done in India at 10 years, carried out in the Rural Tertiary Care Center of Central India from 2005 to December 14, which revealed that around 35% of the males had a normal semenogram, whereas 64% of the male had an abnormal semen analysis report. And when we compare and see for the sperm density, which was decreasing and the volume has been decreasing for the past 70 years, 20% of the drop in the sperm volume is seen and 58% of the decline in the sperm production, which has been observed. There is a known fact that the failing testosterone levels along with the age is seen, and men in their late 40s and early 50s to experience a loss of sex drive, impotence, and depression. This is due to a natural reduction in the testosterone production. By the time man reaches around 40 years, his testosterone will be approximately half of what it was in his 20s. And at 50 years, the testosterone level would be 1/3, and at 60, it would be reaching to around 1/4 or less. The semen sperm morphology, there is morphology could be at the tail end, the midpiece, the head, or the acrosomal reaction end. The A1 is a normal sperm head. What we can see, the abnormal sperm head would be, it could be the elongated one, or it could be a bigger head, or it could be any other, or there could be a globozoospermia where the acrosomal cap is missing out on it. So the morphology can be in any part of it, either in the head, the midpiece, or the tail. There are many multifactorial etiologies for the male infertility. Either it could be because of the aging, impaired cellular functions, the vulnerable diseases, modification of the reproductive hormones, or the late onset hypogonadism, or the genomic instability could be seen. The lifestyle factors, they play a major role nowadays. That is obesity, alcohol, tobacco, high energy intake, nutritional poor food intake, recreational drugs if the patients are using more, or a major factor is stress and anxiety. The physio or the pathological causes are all which are enumerated, and the radiation and the environmental factors which are coming up in a bigger way nowadays, which would be dealt. Let's understand the different causes of the male infertility at various different levels. The problem could be at the hormonal control, at the pituitary level, from where the hormones which are released, the LH, the FSH hormone which is released, that could be a problem. Or then coming down, lower down, it could be the problem where it has to act finally these hormones. That is at the testicular level. Either it could be the blockage of the sperm, the transportation, or it could be the manufacturing defect. The blockage of the sperm transportation could be because of the infection or the prostate-related problems, or the absence of the vas, or the vasectomy if the patient has undergone. Or the reduced sperm production could be because of the genetic causes, the failure of the testes to descend, infections, torsion, varicocele. If the patient is put up on some of the drugs, that like diabetic drugs, the radiation damage, or the sperm antibodies, or it could be the erectile ejaculation problems, that is prostatic surgery, or the damage to the nerves, or the problems in the ejaculations. The other factors would be like the semen disorders could be just general disorders of around 10%, or varicocele, or the cryptorchidism, or the idiopathic causes which are around 1/4 for these all men. A word about the endocrine evaluation for the male partner. The hormonal abnormalities of the hypothalamic pituitary and testicular axis are well recognized, though not common causes for the male infertility. extremely uncommon in men with normal semen parameters, which should be performed. An abnormal semen analysis, especially if the concentration is less than 10 million, there we need to evaluate for the endocrine factors, impaired sexual functions, other clinical findings which are suggestive of specific endocrinopathies. There also we need to evaluate the hormonal levels. The hypothalamic pituitary testicular axis, at puberty, both FSH and LH are required for initiation and complete spermatogenesis. Afterwards, the sperm production can be stimulated with HCG alone, but both FSH and LH are necessary to maintain the qualitative normal spermatogenesis. There are various symptoms which suggest hormonal deficiency when we clinically examine a male. There could be a poor facial or the body hair development, decreased shaving frequency, sexual dysfunction, gynecomastia, fatigue or depression, or the muscle weakness, osteopenia or the fractures, small testes, absence of the male pattern of balding could be seen. When we are taking a history, the detailed history has to be taken with the diabetes, if the patient is having any diabetes or thyroid disorders or the Kalman syndrome or Klinefelter's. And in all these patients, we need to get the serum FSH, LH, testosterone and serum prolactin done. And in those cases only where the semen count is less than 10 million, there we need to do it. Many men with abnormal spermatogenesis have normal serum FSH, but a marked serum FSH is clearly indicative of an abnormality in spermatogenesis. And when we are doing an endocrine evaluation of the male partner, normal testosterone level, if the patient is having around 300 to 1200, it is considered as a normal testosterone level, and the problem would not be at the HP, hypothalamic pituitary testicular axis. Prolactin levels are more likely to be associated with reduced libido and erectile disorders, and mild elevation of prolactin, which is not significant many a times in males. Oxidative stress and infertility is another big chapter on its own, and the role of reactive ROS in sperm functions. If the ROS is in the normal range, then the spermatogenesis, chromatin compaction, and the mitochondrial capsular formation occurs healthy way, and it helps in capacitation and the hyperactivation of the acrosomal reaction and fertilization of the gametes. And if the ROS is elevated, then the apoptosis can occur, the DNA damage and the lipid peroxidation occurs. And these oxidative stress ultimately could be because of the environmental or the lifestyle factors or the systemic pathologies like the diseases what they have. And ultimately this would lead to infertility. Effect of short abstinence in sperm function, that is decrease in the length of the abstinence, leads to a reduction in ROS levels and an increased antioxidant level, which consequently reproduces the rate of sperm membrane and lipid peroxidation. Hypertension and the development of oxidative stress is also known. In the occurrence of hypertension, there is a proliferation of the vascular smooth muscle and the narrowing of the vascular lumen. The narrowing of the vascular lumen leads to increased generation of ROS, thus causing oxidative stress. Obesity is also another important factor which is to be taken into account, one of the 4 factors, and it increases the metabolic reaction due to elevation of the glucose and the lipid levels, increases the level of stress hormones and the proteins, and alteration in the genetic composition is seen. Obesity, again, it increases the adipokines, leading to increased estradiol level and decreases the GnRH and the pituitary LH and the FSH ratios, and thereby thus at the testicular level decreasing the inhibin B, the testosterone level also decreases, and ultimately leading to subfertility for the male factor. And these adipocytes, adipose tissues, again at the pancreas level, it increases the insulin level, and a sex hormone binding globulin also decreases, thereby the testosterone level decreases in the male, and male pattern of infertility is seen. genetic factors, lifestyle and environmental, they also have a huge role to play. Lifestyle changes such as smoking, alcohol consumption, increases the stress and obesity in all contribute towards a decline in the semen quality. Environmental factors like high temperature, increasing exposure to ionizing radiation, and excessive use of cell phones all have negatively impact on the male fertility. And it is clear that the fetal development period between 8 to 14 weeks in humans is extremely crucial for optimal fetal testicular development. And it is also known that exposure to EDCs prior to puberty can still lead to adult diseases and testicular dysfunction. And this is because of this masculinization programming window, which is seen between 8 to 14 weeks. Environmental factors, there are various environmental factors which are affecting the male infertility. The endocrine disrupting factors are described as chemicals which are present in the environment of humans and wild, that by the virtue of that ability to interact with the endocrine system are causing a variety of adverse health consequences. The endocrine disruptors are suspected to be linked to cancers, neurological, immunological, and the reproductive diseases. The phthalates are present in the plastic industry, which is again increases and mimics the estradiol. The alkaline phenols show again estrogenic activity, which are available freely in the domestic detergents, and bisphenols, which are widely available in the, and another estrogenic compound which is there, which is seen in the food cans, the preserved foods, whatever we are eating, and lindane, the DDT, which is widely used in the agriculture. And it is now widely becoming clear that wide variety of both man-made and the natural compounds that are capable of mimicking estradiol and of having androgenic properties. And thus, all these increase the oxidative stress, alter the testicular histology, increase the sperm DNA damage, thereby altering the sex hormone serum levels, leading to male infertility. And all these have an impact on the lifestyle factors of the male infertility by decreasing the sperm concentration, reducing the sperm motility, abnormal sperm morphology, and increasing the sperm fragmentation index. A word about the treatment approaches. The treatment, basically, it is the antioxidant therapy for the male sperms where the ROS is increased, and avoid smoking, alcohol use. And if the sperm count is grossly low, there the patient has to be referred to the infertility clinic, and the ICSI or the ART cycles, IVF has to be done for these patients, mostly the ICSI cycle. And if anti-sperm antibodies are high, then the steroid therapies are given to a certain extent only. Coming down to a word about the management, the clomiphene citrate, the nasal testosterone gels, aromatase inhibitors, gonadotropin therapies, and antioxidants are to be given, supplemented for these patients at times. And apart from this, the other infertility treatments, the ART treatments can be offered to these patients who are having difficulty in conception, like the IUI cycle can be given, or if the sperm count is less than 10 million, then the patient has to be offered the ICSI procedure for them, or much lower the sperm count, then ejaculated duct puncture and the resections and the IMSI can be done. Male subfertility is a significant issue that can have various causes and implications. It is crucial to understand that subfertility does not imply sterility. Several factors that can contribute to male subfertility include hormonal imbalances, genetic abnormalities, lifestyle choices, environmental factors, and certain medical conditions. While male subfertility can present challenges to couples attempting to conceive, that are various strategies and interventions available to address this issue, seeking appropriate medical guidance, making a positive lifestyle choices, and considering assisted reproductive technology can significantly increase the chance for achieving successful pregnancy and parenthood. Lifestyle plays a major role in optimizing functions for the male reproductive system. We have seen a major shift in the choices pertaining to our lifestyle over the past 50 to 100 years. Sedentary lifestyle, lack of physical exercise, and increase in the consumption of alcohol, tobacco has played a havoc in our lives, what we've understood till now. Butterflies may be better indicator of a health of our environment than the birds. So look for butterflies and look for a healthy environment so that we have a healthy world around. Thank you.
Thank you, Dr. Raki, for your wonderful presentation. And you have covered the entire spectrum of male infertility. Now, I have one question that you put it that 68% of men have abnormal semograms. So, what is the fecundity rate in that 68% abnormal? Do you have any idea? Or?
Ma'am, no, it was just a study which was elaborately done and which was stating that the semnogram, there was some parameter or the other parameter which was abnormal in those all semen analysis, which was done for the period of last 10 years, for a decade, more than a decade, which was done. And definitely the semen quality, otherwise also what we are seeing is the quality, the count, the morphology, everything is declining because of the rise in the environmental factors, what is happening to all of us. And over the period of years also, the semen quality and the count, which we used to see 10 years, 20, 15 years back, and the number of the sperm count, which has decreased. The WHO itself was having a higher count of cutoff of 20, and it has reduced it to 15, the sperm semen count also.
Yes, I totally agree. When we were PGs, it was 60 to 120 million.
Yes,
but now it has come to 20 to 40 million. Okay, thank you.
Thank you.
Yes. We'll move on to the next
Thank
session.
you, Doctor. Yeah, thank you, Dr. Raki, for that wonderful talk. Let's move on to our next session. And I would like Dr. Chandra to again chair this session. And I would also like to invite Dr. Latha. She is joined, and I would like her also to chair this session. I would like Dr. Latha to introduce our next speaker, Dr. Fahim, who is going to speak on recent updates in the management of oligoasthenoteratozoospermia. And Dr. Latha is the sitting president of Pondicherry OBGYN Society. Over to you, Dr. Latha.
Thank you, Dr. Chaitanya, and thank you, Madam Dr. Chandra. I'm happy to co-chair this session. We'll move on to introduce Dr. Fahim. Fahim is basically graduated from Maharashtra University of Health Sciences, and he's a consultant and general surgeon in Rajajeshri Medical College Hospital at Bengaluru. Also a consultant urologist at the same place. I think he has a vast experience in managing oligoasthenozoospermia, and he's member of many of the societies. Without wasting much time, I think we have to go on with Dr. Fahim's talk, because this is, in our infertility clinic, when we see, especially those who require IVF, we see, I think it's more than the female problem, the male problem, which requires ART rather than, the female problem. Somehow we keep seeing a lot, and sometimes it's very frustrating because nothing seems to be helping them, sometimes not even IVF. So I'm sure Dr. Fahim will give us a way forward how to manage these patients. So over to you, Dr. Fahim.
Good evening, everyone. It's a pleasure present here and presenting my views on recent management in dealing with basically oligoasthenoteratozoospermia. Just a moment. I want to share my slide to do it. Perfect. Okay. My focus will be absolutely on the current scenarios which are going on and how we will be able to optimize male factors so that I'll be able to give good quality sperms to you to do get natural pregnancy or any form of ARTs. So what is the recent advances which is going on? I'll just give a very brief view about that. Initially, OATS, oligoasthenoteratozoospermia, was is a very common term used among urologists, reproductive medicine specialists, gynecologists, obstetrician in terms of numbers, the motility, and the normal forms of these sperms. We call right now, it has fallen into the gray zone of male infertility. The reason being, there is no specific male factor treatment for this, and the exact diagnosis, the exact guidelines, how to proceed, what next. So there is always a lot of confusion regarding among each and every clinicians, how to go about it and what exactly to treat this male factor infertility, especially falling into gray zone. Azoospermia per se, where there is no ejaculate in the semen, has his own guidelines-based management. It can be divided into obstructive, non-obstructive azoospermia. But oats is one of the things which is a vast subject on its own. But currently, since 2020, oats, according to WHO 6th manual, oats is only to eat, but it is not to measure. The editors of the recent WHO manual have shown that the normozoospermia, asthenozoospermia, necrozoospermia, they are all meaningless, and it requires multiple criteria to establish a diagnosis on a male infertility. Based on only number, the normal forms, the motility, we cannot exactly judge a male factor based on only one particular parameter. It has to be hand in hand, and it has to be multiple factors which come into play to term a patient into what kind of male fertility problems he's facing and how we can treat it stepwise. So the 6th WHO manual has abandoned this reference values, and it has taken and reported as useful values. And the 6th edition has clearly specified that the 5th percentile is only a way to interpret, but not sufficient enough to diagnose male infertility. Now, over a period of years, we have started evolving from labeling a patient as fertile or infertile to diagnosing a male infertility and going for a management. Optimization is the key. Also, there is more precise evaluation and reporting at low sperm concentration. Before, what used to happen is, according to WHO 5th criteria, only less than, if it is less than 2 million, it will be reported less than 2 million. Rest, nothing will be reported. Now with current 6th manual, we have to report less than 2 million, how much, what is the normal form, what is the motility. Now, as I've told you before, this threshold reference values have now been described as useful values, and these are having statistical significance because they have taken number of people, continent studies, review of literature, everything into picture, so that these values have become more statistically relevant as compared to the previous manual. So if we see WHO 2010 5th manual and WHO 21 6th manual, the 5th percentile values are almost same, but they are slightly more scientifically determined and backed based on their scientific evidence and statistical evidence. The only changes which we have seen majorly is in motility, which was initially 40%. Now we have gone to 42%. For the and progressive motility has been decreased from 30 to 30%, and immotile sperm from 22 to 20%. Now regarding motility, the recent WHO 6th manual has taken back the 4th WHO manual parameters. The total motility has to be divided into progressive and non-progressive, and the progressive has to be divided into rapid motility and slow motility. It has its own significance and importance. So it can be graded A, B, C, D, and everything in addition becomes the total motility. Regarding sperm count, as I've told, that less than 2 million initially was not reported. It was just told that it is less than 2 million, but now we have to precisely address less than 2 million, its motility as well as normal forms. And for normal forms, there have been better picture and morphological assessment with HD pictures, which has been labeled into the manual to describe the morphological anomalies of the head, body, and the tail of the sperms. So The oats, which was there over a period of years, which was into the clinical practice, has been divided. It's in the oats patient male factor who falls into oats. Basically, now they fall into something called as borderline category and pathological category. The WHO sixth criteria has divided the patient's male factor. We will not say fertile men or infertile men. We will say they fall into something called as normal category, borderline category, and pathological category. So the oats per se, male factor patients, they fall into something called as borderline and pathological category. So this is a very important slide, which shows the decision limits concept is an attempt to only emphasize the purpose of semen examination. It is not to label a man fertile or infertile. There might be some men who will be fertile in borderline category also. But it is rather a next decision step to further evaluate and manage that. Those in borderline decision limit patients may improve and may require further evaluation, and if there is a correctable factor, definitely we can treat, and we can he can have his own child. So the normal reference value, I was told, has been replaced by decision limits in WHO sixth manual. A normal concentration of more than 20 million is considered to be normal. For borderline is 10 to 20 and pathological is less than 10 million. For motility, more than 50% progressive is considered normal, borderline 35 to 49%, and pathological less than 35%. Whereas for morphology, more than 14% is normal, borderline is 4 to 13%, and pathological is less than 4%. So management decision making for a male infertility, whenever a male factor comes to me, my decision making always depends upon what is his semen parameters, his detailed history taking. Apart from that, I will also consider female factor, age of the couple, duration of marriage, the past history of natural pregnancy, IUI, HC, and obviously the ART Act of India. It's like I always tell the couple, I'm trying to make curd and rice. If I'm determining the rice, I need to know how much is the curd. So my aim is to optimization of sperm, prolonging fertility, and de-escalation. In terms of my intent will be intent to cure rather than intent to treat. My aim will be to go from de-escalating the patient from ICSI to IUI to natural pregnancy, and my treatment intent will escalate from natural pregnancy, IUI, and ICSI. So what next we can plan? Ideally, for oats, as I've told, everyone will give a wide range of treatment options, because there are no guidelines per se, as we have in oncology or any immunotherapy or any various disease. So the range of management, there is no exact precise management in oats basically. But if we try to understand the physiology and stabilize it, we might get the patient from pathological towards border or borderline patient towards normal, so that we'll be able to give something natural pregnancy for the patient. So the treatment will vary from either we do an advanced semen analysis and understand what is the concept, where is the problem, and try to rectify it. Antioxidants, surgeries, hormonal manipulation, and lifestyle modification. These are the treatment options which are available in our platter, and it's basically cafeteria approach among many clinicians to mix and match and try to figure out what next we can plan for the male factor. So if we try to do an advanced semen analysis on the sperm, basically, so there is something called as oxidative stress of the sperm. Dr. Rakhi Singh has definitely has given insight on how oxidative stress is detrimental for male factor infertility, as also for assisted reproductive technique. I always recommend to do an oxidative stress on sperm, despite guidelines not recommending at this point of timeline. In future, it will definitely come. But yes, according to WHO 6th manual, ROS has been included in one of the reactive oxygen species determination has been included as one of the uh, uh, major factor to be determined during a sperm analysis. So it's a proven phenomenon that oxidative stress will cause an inflammatory response and ROS generation, and it will affect spermatogenesis. And this inflammation will cause affect the testicular function in terms of steroidogenesis and spermatogenesis, which will cause subfertility and infertility. This inflammation will affect from the germ cell at the level from the germ cell to forming of mature spermatozoa. So the thing is, the toxic effect starts from the baseline. It is not after in the midway. Plus steroidogenesis is get affected, which is required for the maturation as well as development of spermatocytes, spermatids, and spermatogonia and mature spermatozoa. So I'll just briefly tell you what is the physiology of seminal fluid because and its clinical implication. I'll just run through it. Seminal fluid is consisting of seminal vesicle fluid, prostatic fluid, epididymal fluid, and bulbourethral glands. Each have its own specific function. If we consider seminal vesicle fluid, it provides an alkaline pH to neutralize the acidic vaginal pH, coagulum formation, maturation in the female genital tract, chromatin integration is important, and suppress the immune activity in the female genital tract. Whereas prostatic fluid has only one function. It will cause liquefaction of semen and it has nourishment of this sperm. Epidermal fluid and testicular fluid has a major role basically in terms of maturation, motility, structural rigidity, survival, and its maturation from the rete testis to the epididymal transit. So if you try to figure out detailed semen parameters on a semen analysis, we'll be able to figure out what organ is involved. And if we try to rectify that, I'll be able to optimize that sperm for whatever reason. It can be natural pregnancy, TIOI cycles, IUI, or any ART. So my expected semen analysis, if there is an imbalance between seminal vesicle and prostate secretion, will be either it might be low volume, significant pus cells, abnormal liquefaction, which is seen in, I guess, every second semen analysis. It may be associated with abnormal viscosity and acidic pH. Acidic pH is usually not seen unless there is an obstruction to the ejaculatory duct. So my basic semen analysis report, if I see, if pyospermia, that is more than 1 million of sperm WBCs are present, or anti-sperm antibodies or sperm agglutination is present, I will try to figure out when I get the report in my hand according to WHO 6 criteria, which part of the organ is involved of that reproductive tract. Either the testes, if it is involved, there will be severe decrease in the count, motility, and normal forms. The vitality test and the DNA fragmentation index and ROS might be high or low. Whereas if epididymis is involved, there is more problem at maturation, decreased lipid because of the lipid content of the membrane and fragile rigidity. So they will be low count, low motility. They might be azoospermia if obstruction is there, and altered DFI ROS. If accessory sex organs are affected, definitely I will tell you in detail in next slide how we'll be able to combat that and figure out that accessory sex organs are involved. So much of reactive oxygen species we talk. Is it required even physiologically? Yes, it is limited. In limited ROS is required for capacitation, spermatid differentiation, acrosomal reaction, and hyperactivation. In fact, immature sperms which are present in the testes are release so much of ROS that may induce DNA damage. And they also cause damage after ejaculation, in vitro exposure, and during epididymal transit. So if we see in this slide, this smoking, alcohol, age, varicocele, and metabolic syndrome, as Dr. Rakhi Singh madam has told in detail the etiology of male infertility, they release ROS via an indirect pathway, and they causes peroxidation of the lipid, which cause double strand breaks, sperm immobilization, and they will damage the sperm wall. and integrity. All this will cause abortive apoptosis, which is very unique to sperm. The sperm will mature outside. If we see by a andro lab technician or the embryologist, the sperm will they will say that the sperm is looking amazing. The normal, it's like the most normal looking sperm is the best sperm. It must have best integrity. But they sperm has undergo something called as restrictive form of apoptosis, which leads to double-stranded DNA breaks and single-strand DNA breaks. They have a capacity to fertilize the egg, but the chances of implantation failure, abortion, all those things increases. So that is very unique. And there is something called as malonaldehyde, which are the markers of perioxidation, which are the future which might come to understand more dynamics of these sperm membranes. So abortive apoptosis is one of the factors causing failure of ARTs or natural pregnancy, especially in borderline oats or pathological oats. And similarly, single strand breaks are also seen, and there is something called as sphingosine 1-phosphate now, which it's in clinical trials, which are used to promote germ cell survival, especially in patients with severe cryptozoospermia who are almost going to go azoospermia. This can be used to help in germ cell survival. So there are various inflammatory cytokines which play a role in causing severe decrease in the numbers, count, motility, and the normal forms, affecting spermatogenesis as well as steroidogenesis in the testes. So cytokine profiling of the semen is going to come in near future, so that we'll be able to figure out what exactly is the point, and we can go at targeted therapies against these interleukins, so that we'll be able to survive those sperms. Specifically, not all inflammation or pus cells in the semen are associated with bacteria, but yes, tumor necrosis factor alpha causes inflammation mediated azoospermia, and interleukin 6 is associated with non-pathogenic inflammation in the reproductive tract. So how does this sperm combats ROS injury? It does with the use of antioxidants which bind with ROS via an enzymatic and non-enzymatic pathway. So if ROS only can help to predict fertility and treat males of fertility, does DFI has any role? Because ROS is taking care of anything. If we combat ROS, then why DFI came into picture of recently? Yes, DFI has its role because we can diagnose, prognosticate, and make a decision for choice for ART treatment. So sperm is always prone to physiological oxidative stress via a direct and indirect pathway. And it has a very limited antioxidant budget within itself, so that it combats ROS generation, because it has its own mitochondria, which has its respiratory tract system, which will generate oxygen radical species, and only 20 millimeter cube antioxidant depots are present, which will combat that, which is very less. So how sperm protects itself? By causing chromatin condensation, and there is something called a steroid formation. The histones, the protamins become the histone, and they say coil around the chromatin, and they condense it so that it is less exposed. It's like keeping the chromatin under a treasure box so that it is not exposed to any oxygen radical species. That's the very amazing God's gift to the mankind base at a very subcellular level. So what are the chances, what are the causes of increase in the ROS and DFI? There might be failure, protamination, chromatin condensation is not that great, or there might be no conversion, a replacement of histone protamin replacement is not happening. There might be a lot of apoptosis. There might be infection, medications, as Dr. Raki Singh madam has told, that medications also play a very important role, especially antihypertensives, post-testicular oxidative stress, iatrogenic damage in terms of storage temperatures. If the sperms are frozen, storage temperature, extended use, handling condition, lapse of time after ejaculation, during processing, during IUI or examination of semen sample may cause increase. It can be iatrogenic also. But naturally, as I always tell, that females are always stronger component than the male. The oocyte and early embryos have shown to have repairing capacity. and they repair some kind of DNA breaks to some extent. So God's gift to mankind in terms of combating ROS and in the natural seminal fluid is the ROS main source is accessory sex gland, and sperm can handle its oxidative stress to some extent. And any oxidative stress can cause DNA damage, which can be diagnosed by DFI. So DFI is absolutely a different component as compared to ROS, and both are required hand in hand to predict inflammation and predict antioxidant treatment outcome, because antioxidants is one of the treatment which is used rampantly by everyone. But do they really work? Slide is not working. Hello?
Yeah, fine.
Yeah, no, my slides got stuck. So current scenario with antioxidants is oxidative stress, as we know, play a major role in infertility. Antioxidants have been given, the current trend is it is more of clinical abuse than scientific use. There is a growing trend without even complete evaluation and relevant guidelines for management of male infertility and use of antioxidants, because it is widely available, safety profiling, bioavailability, relatively cost effectiveness, and to a certain extent also acts as placebo effect. So which antioxidants can be used? There are various antioxidants have been studied, but the most studied ones and in literature are vitamin A, C, E, carnitine, N-acetylcysteine, coenzyme Q10, lycopene. So I will just briefly tell the systematic review regarding antioxidants. There are 5-6 systematic reviews which shows there are no clear recommendations regarding use of antioxidants. It can lower the sperm DNA fragmentation as compared to placebo, but it still has grade 3 recommendation. It might improve semen parameters when if it is associated with varicocele surgery or non-operated varicocele, just to stabilize the sperm so that we'll be able to optimize for our management. It helps in certain cases such as varicocele, unexplained and idiopathic male infertility. Antioxidants which readily cross blood-testis barrier are recommended. Combination is always recommended than single ones. There are RCTs which has low evidence of support, which doesn't support antioxidants in terms of they don't increase pregnancy live birth rates or they don't decrease the miscarriage rates. So as I was telling, how we can interpret if there is on a semen analysis, if we see anti-sperm antibodies, agglutination or pyospermia, we do an reactive oxygen species and DFI. So my clinical scenario will be ROS is also high, DFI is also high. My source of problem is the accessory sex glands. And if I give antioxidants to them, my response will be only moderate, not great. Because the problem is at both accessory sex gland oxidative burst results in sperm DNA damage, which are physiologically weak at baseline. The sperm at the testicular level itself has less of its own antioxidants depot. If ROS is normal and DFI high, it means at the testicular level, the sperms are absolutely at production only, it is having a very bad quality sperm production. So even if I give antioxidant, it will be of no use because ROS is normal. And the third thing is ROS is high and DFI is normal. These are the best people where we can give amazing results in terms of OATs, numbers, as well as motility, as well as normal forms. Antioxidants will work great in such patients. So why these antioxidants are inconsistent or fail? First, there are no 100% studies which shows any guidelines and the treatment protocol, the dose regime, the durations. Second thing is non-proven dosage, it causes body redox imbalance. If we give too low dose, it is ineffective. If we give too high dose for a long period of time, it will cause excess of antioxidant and it will cause a reductive stress, which is more detrimental than oxidative stress, and that will cause more infertility. So one of the most, among the various molecules, vitamin E is associated to have the most adverse side effects over long term. Now, second is always a patient with abnormal semen analysis, varicocele on scrotal Doppler, it is encountered, and surgery. Either there are two clinicians, two schools of thought basically. One will go for surgery, one will opt for no surgery and go for ART. All depends upon, as I told you, the rice and the curd combination, how much I have. But yes, definitely varicocele does affect reproductive potential by causing hypoxia, hyperthermia, reflux of metabolites, and causing elevated ROS and DFI and apoptosis. So this is a very concise slide which I want to mention here. Varicocele doesn't help in all cases. The good prognostic factors are grade 3 intratesticular varicocele, normal hormonal profile, FSH, LH, or no, there is no kind of any dysfunction. And if it falls into borderline semen analysis. Via poor prognostic factors, where I might not able to have any improvement, but yes, definitely I can, I'll be able to slightly prolong his fertility. In such cases like subclinical varicocele, or if it is associated with Y chromosome microdeletion, abnormal FSH and LH, low testicular volume, cryptozoospermia, pathological advanced semen analysis. In such cases, what I do is I always freeze a sample and counsel the risk versus benefit, and I will ask the patient to take their own informed decision, rather than me pushing them for surgery. At the end, we have to give them baby, and at the same time, I have to optimize the sperm, rather than just giving optimal outcomes. So how many days is semen analysis is to be checked, or improvement is to be noted after varicocele surgery? At least 3 spermatogenic cycle, which is around 50 to 60 days. I say it around 120 to 180 days. 3 months later only we have to do his repeat advanced semen analysis. There might be a chance that in between, if the patient does it and if it falls, we should not, we should counsel the patient that it might be a phase of recovery. So in that phase of recovery, there will be a dip, trough, and then there will be a rise. Regarding hormone manipulation, for males, they are very specific as compared to females also. We have very specific hormones to determine, that is FSH, LH, prolactin, and inhibin. I will not take part, I will not consider inhibin at this point of time, because we are considering oats as a management in this lecture. So if hypogonadotropic hypogonadism where FSH and LH is high and testosterone and estradiol are low, it means that there is a primary testicular failure. Mostly the patient will be azoospermic. So it requires a kind of sperm retrieval management, a guidelines-based treatment management. I will not discuss into that. Regarding hypogonadotropic hypogonadism where FSH and LH is low, testosterone will be low or normal, because adrenals will also
Excuse me, Dr. Fahim, sorry
Yes.
to interrupt.
Yes.
It's already overshoot the time. Please.
I'm almost finishing. This is, I guess,
Okay. Thank you.
So in such cases, hormonal manipulation in terms of SCG plus minus SMG can be given. This is the next progressive testicular dysgenesis is one of the most important patients which come into to clinics, where FSH is high normal, LH is also high normal, testosterone is okay, estradiol is okay, but they are progressively increasing their FSH. We have to freeze the sample. We have to plan for the ICSI according to the male and female factor, but freezing is a priority in such cases, because they might go into azoospermia, and we might not be able to retrieve sperms surgically also. Regarding isolated Leydig or Sertoli cells, we need to give SCG or HMG respectively. If it is on a sliter, we can give clomiphene citrate also. For metabolic syndrome, yes, we can just give, if there is T ratio difference, which is normally 10:1, we can give anastrozole. So in conclusion, I want to say we have to target the pro-inflammatory cytokines, which causes male infertility. And the advanced semen analysis, the old oats has been divided into borderline ASA and pathological ASA. We have to check for the correctable factor, manage the correctable factor, and we can plan for TIOI, IUIs. And a trial of antioxidants can be given for patients in borderline category, whereas in pathological, we have to explain the risk and versus benefit, manage the correctable factor, and de-escalate to TIOI, IUI. If no, we can directly go for XC. And yes, all depends upon female factor, age of the couple, duration, past history, and ARTI. Thank you. I hope I have not bored you guys.
Thank you for that wonderful.
Thank you, Dr. Fahim, for your extensive, elaborate presentation. It was very nice.
I would like Dr. Chandra and Dr. Lata to give the concluding remarks for this talk so that we can move on for our next session.
Yeah, I think as he said, DFI and ROS are no doubt very important in oats, but only thing is the cost factor. How many of the patients can afford? So I think if there is something which is, that's what I wanted to ask, if there is a clinical way of assessing where ROS is high and DFI is low, in those patients whom we can give antioxidants, that will be a good take-home message for everyone.
What we can do is borderline semen analysis cases can be given a trial of antioxidants for 1 to 3 months. And then we can, if it is borderline, definitely that a couple can go for TIOI. But if it is still not happening, then we have to dig in. What is the problem?
Yeah. So another thing from what study we had done, we saw that for counts and motility, it was good. But morphology, I mean, it was not good. That too, again, if it is borderline. So I think with that point, we can proceed with the next session.
Morphology is one game that we can transfer the patient from OI, TI to IUI or ICSI.
Yeah.
Okay.
Thank you.
Good evening. I was a bit late. Okay, anyway, I joined this session. It was an elaborate lecture by Dr. Fahim. I have one question. I mean, suppose if the patient is having normal semenogram or normal semen analysis, and still the patient is not conceiving, even after rule out all female factors also, when to repeat the semen analysis again after 6 months or 1 year or 3 years?
My first query in such cases will be, is the couple really consummating the marriage or not? If it is normal from both the ends, why is it not getting consummated? Why the baby is not forming? At least some natural pregnancy should happen. So I will dig into sexual dysfunction on both the sides. And if sexual dysfunction, most of the time, 90% sexual dysfunction is normal.
Ma'am, if the semen analysis is coming as normal, first and the foremost thing what we have to see is where the semen analysis was conducted, how it was conducted, how the semen sample was given, because that is the basic crux of it. Many a times a patient gets the semen sample from the house. It could be a very bright chance that the patient is not giving his own sample and getting somebody else's sample. So that has to be stressed and specified that the semen analysis has to be done in the center and with a good abstinence of 2 to 3 days at least minimum, and then do it. And if suppose there is an abnormality which is found on the semenogram, we need to repeat the semen sample, say about after a week or so or after 1 month or so, and the patient has been put up on medication, then the repeat sample can be done after 3 months or after 1 month, depending upon the requirement and depending upon the urgency of the treatment. And if the patient is not conceiving, very rightly said, and the second thing is the cohabitance of the consummation of marriage has to be taken, and the frequency of the intercourse has to be noted from them. These are few guidelines, few important points. See, there are couples who will not consummate or who are not active with their family life also. And they want the things to happen with just one or two hits. That is absolutely not possible many a times, because that may be the right one or that may not be the right time when it is happening.
Yes, sometimes we can ask them to undergo postcoital test, no? To find out.
Yes,
all those
postcoital,
things.
definitely, ma'am. That is
Yeah.
another way to understand whether they have consummated or not, whether they're doing it correctly or not.
Yes.
Correct way to do it or not. And
also regarding
right
the
now,
antibodies, PCT
Yeah,
will
Chaitanya?
also tell us. PCT will also tell us regarding the presence or absence of antibodies.
yeah, presence or
From the
absence of
dead or
antibodies.
live.
Yeah. For this today's webinar, again, we have got the Vice President with us, Dr. Gitendra Sharma, under whose able guidance we've been doing this endocrine committee is under him. And he is a practicing gynecologist and obstetrician at Ahmedabad for the vast experience of 30 years and a medical legal counselor with 15 gold medals from the Gujarat University. He has authored many books, The Law of Obs Gynae Practice, Consents in Obs Gynae, Laws a Doctor Must Know, given more than 1,600 lectures, 10 orations all over India, Vice President of Foxy for 22-23 this year, and Chairperson for Ethics and Medical Legal Committee of Foxy from 2017 to 19, and the President of Ahmedabad OB-GYN Society from 16 to 17, and he has hosted AICOG Ahmedabad in 2017. Joint Secretary of SACOG in 2017 to 19. I hereby present Dr. Gitendra Sharma for his kind words for address and for all of us.
Thank you very much, madam, for inviting me.
Thank you, sir.
And at the outset, I would like to thank my colleague, Dr. Rakhi, who is chairperson of Endocrinological Committee, for giving me this opportunity to be with you all in this webinar. I also pay my regards to Dr. Pai sir and my colleague, Dr. Madhuri Patel, who is secretary in Foxy. Through you, I can meet many of my friends today. I can see Dr. Chandra is there, Dr. Latha is there. Yeah. Then Dr. Jyoti is there. And I want to thank also Dr. Chaitanya Ganpule, sir, for inviting me for this webinar. I can say that Rakhi is doing very well. She is handling the endocrinological committee, conducting many published material she has come out with. She is always active in coming out with different posters and other things. So I cannot enumerate her work done as a chairperson of endocrinological committee, and I have great respect for her. Dr. Chaitanya Ganpule is also, I have come to know that he is moving all over India for doing different kind of surgeries. So he is a dynamic person, and I give my best wishes to him for his endeavor in Foxy elections in near future. So Dr. I can see Nilesh is there, Dr. Meenu Handa is there. So today I am happy to meet you all through this webinar. And thank you once again for giving me this opportunity. I pay my regards to President Namakkal, Thanjavur and Pondicherry Society. So thank you very much for giving me this opportunity. Thank you.
Thank you, sir, for the kind words. And we have got the next in line with us, the much awaited and very important panel for us, which is on
Hello.
For this panel, I would like to invite the chairpersons. There are no chairpersons.
No, that's a panel discussion, na, Raki?
That's a panel discussion. Why is he putting that? Dr. Chaitanya's slide I should have.
Yeah. Nilesh?
Yes, sir. Good evening.
Good evening. Acha, can I start sharing my screen?
No, first let him share your this. Na?
Nilesh, can you share my CV, Nilesh, of Corona Remedies?
Yeah.
Okay, there it goes.
We have got a dynamic Dr. Chaitanya Ganpule, who has been the mastermind behind this. And he is a gem for my endocrine committee of Foxy also. And we have been moving around and working hard since the start of my tenure where I have taken. And he is the national coordinator for the endocrine committee of Foxy. And he's going to do he's done, he's the director for the Pearls Women Hospital at Yash IVF Pune, director for the Noble Yash IVF, director at Satara Yash IVF. He's handling multiple IVF centers and recipient of Times Health Icon 2020, invited faculty and publications in the national and the international journals, written chapter at Jeffcott Textbook of Gynecology. You will find Chaitanya at many places in India also. And he is going to teach us about what a gynecologist should know about the level 1 ART clinics in India and how every gynecologist should get registered or should not get registered who are doing infertility, and to what extent we need to understand that. Over to you, Chaitanya.
Thank you, Dr. Aki, for that kind introduction. I'm not going to teach anything, but I'm just going to
Hey, we're going to learn about it, right?
I'm going to facilitate. Dr. Gitendra sir is there as our expert, who is a medical legal expert, and that's the reason why he is there as an expert for today. And okay, can you? Right, and we have got the panelists: Dr. Gayatri Ganeshan Ram, Dr. Hemalata, Dr. Uma Brinda, Dr. Kubera, Dr. Meenu, and Dr. Nilesh, who comes from my city. So all of them are going to interact. And then I would request Gitendra sir to give his expert comments whenever he feels like. And then at the end, I'm going to have some FAQs, which I would like Gitendra sir to clarify that, so that all of us are on the same page when we start with the practice as an ART consultant. As you all know that the ART bill or the ART Act has been going on in for quite a long time. It was in discussion for almost last 10 years or so by the NCA, and then ultimately the ART Act came into existence in December 2021, and then it was in force from January 25, 2022. So let's quickly go through what is this ART Act. An act for the regulation and supervision of the assisted reproductive technology clinics and the assisted reproductive technology banks, prevention of misuse, safe and ethical practice of assisted reproductive technology services for addressing the issues of reproductive health where assisted reproductive technology is required for becoming a parent or for freezing gametes, embryos, embryonic tissues for further use due to infertility, disease, or social or medical concerns, and for regulation and supervision of research and development, and for matters connected therewith or incidental thereto. Now, the language is a little difficult one for us to understand, but it has to be the way it is in the act, and that's the reason why I've just copy pasted it, so that there won't be any lapses when I try to write the same thing in my own language. I would like my all panelists to introduce themselves once I start with the questions before they actually answer the question. So Dr. Gayatri, I would like to ask you, what is a level 1 ART clinic? They have divided it into level 1 and level 2. Then they have given the definitions of level 1 ART clinic and level 2 ART clinic. So can you just elaborate on what is level 1 ART clinic, what is level 2 ART clinic maybe, and what is the difference between the two?
So level 1 is where only intrauterine insemination is carried out as a part of the treatment, sir. Level 2 is where you carry out IVF ICSI also along with IUI.
Okay, Jitendra sir, you would like to put it in a different way than what she has just put? Hello? Achha, Jitendra sir, I think he has got disconnected.
Yes.
Sir, do you want to add to what she has just said? That we were just discussing about what is level 1 and level 2 ART clinic. So she said that level 1 is the one where only intrauterine insemination procedures are carried out as a part of the treatment, and level 2 is where IVF ICSI is done. Is that correct, or you need to add? You want to add something to the level definition of level 2?
No, definitely. All ART procedures can be done in ART level 2 clinic. And if you want to do only IUI, not other ART procedures, then you have to register as an IUI clinic, that is ART level 1 clinic.
Level 1 clinic. So it's the clinic where only IUI procedure can be carried out. Anything other than IUI or more than IUI cannot be carried out at a level 1 clinic. So Dr. Hemlata, what are the staff requirements for this level 1 ART clinic?
Unmute yourself, madam. Madam, unmute yourself. You are mute.
Yeah, the staff requirement is a minimum of postgraduate obstetrician and gynecologist for this level 1 ART clinic, along with whoever the staff is assisting, like a nursing staff we can have.
Okay, so there is a need that there should be minimum 1 gynecologist. And as you rightly said, the gynecologist shall be a medical postgraduate in gynecology and obstetrics. So other than this, no one can start or have an ART, level 1 ART clinic. So if you are an embryologist, without a gynecologist, maybe you will not be in a position to start an ART1 clinic unless you have a gynecologist on board with the desired qualification. Correct?
Yes, sir.
Why my screen is not moving? Okay. So, Dr. Uma, what are the equipments that are required for a level 1 ART clinic?
Good evening, sir.
Good evening.
For level 1 ART clinic, we need a centrifuge for processing of semen sample, a microscope for examination, and a refrigerator to store the medium and all. These are the basic requirements for level 1 ART clinics.
Correct. So there are only 3 things which are needed to start a level 1 ART clinic: microscope, centrifuge, and a refrigerator. So there is no mention of laminar flow or positive ventilation or anything to start a level 1 ART clinic. Jitendra sir, what is your take on this? Should we have it, or by law it's not needed, but for better clinical outcomes, maybe it's good to have a laminar flow in addition to the list which they have mentioned?
Yes. So as you have rightly said, these 3 things are mentioned, but it is always better to have laminar flow as a standard practice of doing IUI.
Correct. So there is something which is minimum requirement by law, and there is something which you can add on to what other than what is needed by the law to improve your clinical outcomes. And finally, that's what matters for all of us. So rather than just sticking to what the law asks us to do, if we can have something more than that, which is going to add on to our clinical outcomes, that's always good to go with. Okay, can anyone start doing IUI in their clinic? Suppose I have an OPD of my own and I just want to start doing IUI in my clinic. So can anyone start doing IUI, or is there a procedure that needs to be followed if I have to start doing IUI at my clinic?
Good evening, sir. Can you hear me?
Good evening. Yes, we can hear you.
Thanks for the opportunity for all the organizers. So no person can start or establish a clinic or bank for doing assisted reproductive procedures unless that particular clinic is registered under this particular act. So it is not like starting a general practitioner starting anything and all. So it needs to be registered, and that it has to go through the process.
Correct. So I rightly said there is a process that needs to be followed for the registration for level 1 ART clinic to take place. And once you have got that registration in place, you can start doing IUIs at your clinic. But if you see the requirements which they have given, the personal requirement, the equipment wise requirements, it's not a very long list. So it's not that difficult for anyone to establish a level 1 ART clinic, though you need to follow a certain procedure, but it's not very difficult to have a level 1 ART registration and start doing an IUI process. So let's not get afraid of the law or whatever has been put forth, and let's not go back. We don't want to get into all this, and we should not register ourselves for level 1. No, you can do that. Now then again, the next question that comes, okay, fine, if I have to apply for the registration, how do I apply? Where do I apply? And what should I expect when I when I start the process of registration? Dr. Minu, you have your own center. You must have gone through all these registration processes in the last year.
Yeah. Hi, good evening, Dr. Chaitanya. Good evening, Gitendra sir. It's a pleasure to have you here. As you rightly mentioned, that it's not, we don't need to be afraid of it and follow the correct rules. Anybody who wants to register as a level 1 clinic can go to the link of registry.artsurrogacy.gov.in. And when you go on to that option, when you click on to that, we need to go to the ART clinic segment. Click on that and you get the different categories. And when you open the form, you need to go to your ART level 1 clinic and specify about IUI. Select only IUI. They will ask you various IUI, IVF or ICSI. You have to select only IUI. And this is how the National ART and Surrogacy Clinic, the website it was shown. And so you can go ahead, click on that. And many times as a gynecologist, if you have a director or a owner can be there. And if you are the person who's also owning, then it can be the same or it can be different. It's up to them. And you can write your name in both the columns and proceed forward and then do the registration according to this.
So why they have specifically probably mentioned director different and gynecologist different, that so that Gitendra sir, does that mean that the IUI clinic or the level 1 ART clinic can be owned by a non-medico or by a non-gynecologist first, and she can appoint a gynecologist and register for level 1 ART clinic and do the process?
Yes, I think so. It is the
Yes.
director can be,
Yeah.
need not be a doctor.
So rightly said by Dr. Minu that anybody can be the owner of IUI clinic, but the person who works for that should be a gynecologist. Now, one thing I will like to make a comment here, that the qualification for a gynecologist for ART clinic level 1 and level 2 are different according to Act. So in level 1, any gynecologist who is having postgraduate qualification, that means it can be postgraduate diploma or postgraduate degree. But in ART level 2, it is specifically mentioned that only postgraduate degree holder. So the problem is that different authorities are interpreting it in a manner that DGO or a diploma holder gynecologist should not be given the registration for ART level 2. So that is the thing which needs to be clarified, and it is not uniformly interpreted by different appropriate authorities.
Is there any RTI which has been filed with getting for the clarification of this, what you just rightly said, sir?
Yeah, definitely, sir. There are multiple RTIs. Even I can quote more than 100 RTIs are being filed by one person from Chennai only. There are different answers for that. So in that, they give answer in such a way that the answer of this qualification is given in this section. So please read this section. Now, reading that section is okay, but what is the interpretation of that section? They don't do in the answer of RTI.
Okay, so still there is no clarification on this.
But in most of the centers, they are not registering diploma holders for ART level 2 clinic.
Okay, that's a very important point was what sir has brought up. Now, sir, I just wanted to know when the clinic is owned by suppose a non-medico, then the name of the director would be of that person. Is it so?
No, it is not like that, sir. A director can be any postgraduate qualified doctor who or person who has knowledge of this ART practices. So director can be non-medico also, can be medico also, but the person who is working should be a gynecologist.
So director need not be the owner of the clinic.
May not be owner.
May not be owner.
He can be the employed person of a corporate.
Okay. Okay. So director need not be the owner. Director and gynecologist might be different. Director could be a medico or a non-medico person, but the gynecologist has to have a diploma or a degree holding in gynecology so that he or she
Director
can be
as such is an optional thing. It is not necessary.
Yes,
it is an optional thing.
Yeah.
So can I just add a, sir, in many of the corporate hospitals also, what they've also done is that for the gynecologist, as sir has also mentioned, it's the fertility specialist name which is going. But for director, even if it's optional and they need not be the owner of the hospital, but they can be like an administrator head or a zonal head, business head, anybody can be there as a director.
Fair enough. So this is how the website looks like, as Dr. Minu rightly said. So Nilesh, what are the registration fees? Dr. Nilesh, what are the registration fees for ART level 1 and where do we have to pay these fees? Can we pay them online? Is there a payment gateway available on the website, or do we have to give in person a check or a DD or what not?
Yeah. So I think the registration fees for level 1 clinic are 50,000 rupees. And those have to be paid physically in the form of either the demand draft, that is the most acceptable way, or the check. Here in Pune and Maharashtra right now, the payments have been done previously to the PCPNDT authorities and the local corporations. Now the state body is thinking of changing the appropriate authority. So probably everything is at standstill in Maharashtra right now in terms of ART registration, surrogacy clinic registrations, everything. So I can comment about that. But they have stopped the payments right now. So right now, if you want to apply in Maharashtra, they have to apply to the national board and they can register over there. The local applications right now, the corporations are not taking it. So the payments are on hold right now. But yeah, the local authority is the appropriate authority would be the best person where you can pay.
So probably they were asking to pay for the fees for those clinics who were already doing ART level 1 work or ART level 2 work before the act came into existence. And then they gave a time period which was extended a couple of times to for these clinics to apply for the registration process, to pay the fees, and also probably the new registrations for new clinics who do want to start. They have not started the registrations for them as of now. Is that what you want to say, Nilesh?
No, for the new clinics also, they initially took the registrations, the applications along with the payments. But right now, the government, the state government at Maharashtra has not set up the state authority. And since the state authority inspection is pending, the appropriate authority here is not taking the applications, new applications right now. They already have taken few applications, even if they were new applications. But right now it is in a suspended state. Probably once it is channelized, the appropriate authority is where you can apply, where you have to pay.
Absolutely. So as you rightly said, in Maharashtra, even Maharashtra in Pune, actually,
yes,
we already received the registration certificates also. And then because the things changed in such a way that the state board or state body should come and inspect the place, they took back the certificates which they had issued, and now probably the state body will come and do the inspection. Gitendra sir, what is the situation in other states or nationwide?
Gitendra sir, one more question to you. If you see the Chaitanya sir slide, initially it was shown, the national registry slide. only 210 ART clinics have been registered, and only 78 ART banks and only 122 surrogacy clinics. Out of those applications, we can see the applications are huge. So there is a discrepancy, So some people in Telangana have already started doing surrogacy. We are yet to receive any form of document regarding surrogacy. So what we can do in such situation?
So, sir, 2-3 things we should discuss. First, how to apply. So you have to apply to national, as per law, what is mentioned in ART Act. You should apply to national registry through local appropriate authority. So you have to apply on national registry, and after application, you should send a physical copy of that application to the secretary, health secretary of your state. So that is usually followed by most of the state. Now, in many states, as you have said, that authorities are not formed. And that's why there is delay in process of inspection and giving registration. So even in Gujarat, till date, only 3-4 inspections are done in a few clinics, and they have given one number of one appropriate authority that you have to submit demand draft over there of 50,000 if for ART level 1, and 2 lakh rupees, as we know, for ART clinic level 2. So that is the thing. Now, regarding question of withdrawing that registration, which are already been allotted in Maharashtra, there are some occasions where they have already given the registration, appropriate authority had given the registration, but then they withdraw, and now we are waiting for the inspection to be done by state board. So in that case, sir, again there is ambiguity in the act itself. It is mentioned in the act that appropriate authority has to give certificate of registration, but in after a few lines in the same section, it is mentioned that appropriate authority can issue the registration only after inspection is done by state board, and if they are satisfied that everything is okay. So it is something ambiguous. See, inspection is to be done by state board and certificate is to be issued by appropriate authority who is giving a certificate is not inspecting the place at all.
The local authority in most of the cases.
Yeah. So this is the problem in it. So that's why in Maharashtra, at many places, when appropriate authority already issued the certificate, and once the state board were not formed and objections were raised that why state board has not inspected and you have issued this certificate, so he immediately withdrew all the certificates which he has sent to avoid the controversy. So these are all ambiguities in act. That is the problem. It is going to be a next PCPNDT act only, because there is no uniformity at all in implementation of this act.
So I had a doubt. So can I just ask you? So what should the new clinics do? Because we have if somebody has submitted the form, they have submitted the fees, and they waited for, and they've got the acknowledgement from the national board as well. And
so for, that,
so
madam,
how long?
See, there was provision in the act that everybody who is working from the before this act, they should apply within 6 months.
Right, sir.
Okay.
So that was for previous one. The new ones.
So
what
it
should
was
be?
said that if you have applied before 24 July, then you can continue working. Okay, even if you don't get registration, you can continue working. But there are a few cases where the clinics are new, but they are not granting the registration because appropriate authorities are not formed. So they cannot work as such. So in that cases, we always recommend that go to High Court and explain your case, that nobody can deny you doing practice, as you are, it is a right to profession. So you can go to High Court and you will definitely immediately get the permission. See, for example, in Kerala, you all know that there was a decision. See, surrogacy board were not formed, authorities were not formed, but one patient went into High Court that, sir, my embryos are been frozen for last 8 years for surrogacy, and now you have this different kind of acts, and due to that my age is 49 years now, so I cannot wait further, so please give me the order. So immediately High Court gave the order that you cannot delay a treatment of any patient. And they ordered that clinic to continue with the surrogacy treatment. And they also ordered the government to approve this surrogacy through the temporary or appropriate authority to be nominated. So whenever such thing happens where you don't have answer, or because of delay on the part of government, if something is happening, then you can definitely approach your High Court under writ, and you will definitely get immediate relief in that case.
Thank you, sir.
Thank you, so. And Dr. Minu, it's not only for the new ones. All those who have applied after 24th of July, probably they all will be in the same boat, because they had given that 6 months of time span or time limit for all of us who were practicing fertility before that to apply. So if someone has not applied before 24th July, probably they all will be considered as one and the same. Whether they are new or they were practicing in the past, it doesn't matter, I suppose. Correct me if I'm wrong, sir.
There is one more confusion, sir. Particularly in Maharashtra, what has happened? See, even persons who had applied before 24 July, it was mentioned that they can function up to 6 months.
Correct.
Or till registration is given. Now, the question here is that once in 6 months, appropriate authorities were not appointed. So they came out with one notification that they can continue working up to October. Then they extended that notification up to April or something like that. But in the list of states which were included in that list, Maharashtra was not there. So in Maharashtra, what happened? The people who had applied even for ART registration, who did not get registration, they were not in that notification. So how they can continue practice? That was the question again, once again. Because that previously was containing 17 states, then it was reduced to 10 states. So in the list of 10 states, Maharashtra was not there. So in Maharashtra, you were not allowed to continue practice officially through that notification after the expiry of the previous notification. So although that is wrong, but this was the situation.
Was it by it was not a deliberate thing, or it was why this discrepancy between states? If it's a national, if it's an notification given by the national body.
So maybe, sir, national body might not have information from Maharashtra that whether authorities are being formed or not.
Okay. But in such case, what we should do? I mean, should we say that no, we are also included in it, or we are excluded from it?
So for that, sir, again, we have to approach High Court. That is the only answer.
Thank you, sir. So, Nilesh, continuing with you, what are the preparations that one should do if I have to register myself for ART1, ART level 1 clinic before the inspection takes place?
I think as per the statutory requirement for the ART clinic, we have already seen the gynecologist is required only as a staff. No other staff they have mentioned in level 1. So even if they have mentioned the same, we should have the gynecologist degree certificate, their registration with the medical council, that is mandatory. But along with that, I feel whatever staff is recruited as a protocol, we should have the certifications from them also. So any nursing who is recruited for giving injections, for assisting you, their certification should also be there.
Not mentioned anywhere.
They are not mentioned, but as a protocol, I feel it should be there.
All these things with you at your end, like NABH says that you should have a file for every staff member, and they have given what all things you need to maintain for that particular staff member. That way, in this law, there is nothing which is mentioned.
Nothing we have mentioned. But we should understand that all ART level 1 clinics will have probably an ultrasound as well. And correct. So the appropriate authority are usually linked. So the appropriate authority here in Pune who came for inspection was also the PCP entity authority. So we cannot question them if they ask us something else. So it's always better to be over prepared and have all the documents for supporting for all the staff also. And
sir, can I interrupt 1 minute?
Yes,
do you want to say that the person who is doing IUI, he himself only should do follicular study? He cannot send that patient for follicular study to another sonologist. So can't any gynecologist work without sonography?
No, that is not the case. I'm saying usually, I feel that most of the level 1 clinics may have the ultrasound machine as well. So the appropriate authority is already visiting those centers.
It's
So,
not
But it
mandatory.
is not always there. Sorry
Not
to
always.
jump in,
Not always
Dr.
there.
Raki. It
Sorry
is
for the
not
confusion.
always there that there are many gynecologists who would just register for ART1 because they are just stimulating for that matter and giving gonadotropins. Because even if you are stimulating a patient and putting the patient on gonadotropins, anytime the appropriate authority can come down. But only thing is, if you're doing an IUI or anything, it is not always necessary that the ultrasound has to be there with that gynecologist. But yes, she should be having a place where she's referring for the follicular study. That should have been in place where
So-
the patient is going to get the ultrasounds done.
So, Dr. Raki,
Yeah, Gitendra sir.
stimulating a patient for ovulation induction, does that make a part of the IUI procedure?
no. So, sir, clarity is required here.
It's still the clarity which has to be coming down. There was a PIL which was put in for that. Gitendra sir would be knowing about it. But there is a clarity which is awaited. But it is much better to be safer. And if you are putting the patient on gonadotropins along with oral, it's better to register and then do it under ART1, because anytime the appropriate authority can come and question and ask, because it is a discretion at various levels. Every state is having a different, every district is having a different appropriate authority. Gitendra sir.
Madam, law is very much clear. Yeah, law is very much clear. If you are going to do ART, then only you are supposed to take registration. Now, what is the definition of ART? That you should take out the gametes, either sperm or oocyte, do something with that gamete, do some procedure on that gamete, and then transfer it to inside uterus, either gametes or embryo, after making embryo. So, see, IUI is definitely ART. That's why it is level 1 registration is required. ART level 2 is required for all other ART procedure, ICSI, IMSI, whatever they are. But if you are not doing IUI or ART or any ART, including IUI, then if you only stimulate for timing of coitus, no registration is required. So for giving gonadotropin, this is a misconception. For giving gonadotropins only, we do not require any registration. Registration is required for doing ART procedure.
Absolutely. Now, sir, in this regard, I just want to
I would just like to clear, Chaitanya sir, the point was taken in the wrong sense. I didn't want to mention that every gynecologist requires a scan machine, but most of the gynecologists also have a scan machine. So probably you should be prepared for the inspection by the appropriate authority.
Definitely, Nilesh.
And
that
secondly,
most of them who are doing IUIs do have ultrasound machines on their own. They do their own follicular monitoring, but it is not mandatory that you should have an ultrasound machine on your own to do an IUI at your clinic. Point well taken. Gitendra sir, I was just going to ask you a couple of questions in regarding to this. Now, as Dr. Raki, you said that if I have to take a level 1 registration just for stimulation, I need to have that microscope, I need to have that centrifuge and refrigerator. When I'm not going to do an IUI myself, why should I be investing into it? Number one. Number two question, sir, Gitendra sir, is can a BAMS, BHMS doctor who is not, or a plain MBBS doctor, forget about BAMS, BHMS, MBBS doctor who is not by qualification a gynecologist, stimulate patient with gonadotropins? Gitendra sir?
Yeah, definitely stimulate. He can stimulate. See, somebody
So what is the purpose of
somebody who is qualified to prescribe clomiphene citrate or litros or stimulate for timing of coitus, he can definitely stimulate the patient for that. But you cannot stimulate for ART. So the purpose should be mentioned. No, if you are going to stimulate for IUI, then you have to take IUI consents before starting stimulation. That is Form 7 and 8 are there for IUI, husband and IUI donor. And if you want to do any ART procedure and for that you are stimulating, that before stimulating you are supposed to take consent in different forms. that there are 6 number, 9 number, and 12 number, and all other relevant forms. So purpose defines that if you do not want to do ART at all, that means IUI or ART procedure at all, then you do not require for only stimulation any kind of registration, and nobody can enter your premises and take cognizance because you are not ART registered clinic then.
So that means, sir, if I get a patient from my colleague who has only a clinic and she is stimulating her with gonadotropins at her end, she should be taking the consent form 7, form 8 at her end before she starts with the stimulation. Is
Yes.
that the correct
Yes,
way?
for if it is she is stimulating for IUI, then
Yes,
she
for
has
IUI.
to take consent in
And then
forms
she's going to
1 and
send
form
a
8.
patient, and then she's going to send the patient to me for IUI. Then what should I be doing at my end? Should I be taking the form 7, form 8 again from the couple at my end, or I should take those consent forms which are signed by them in her clinic and keep it for my record?
No, sir. ART clinic is duty bound to take consent. So even if she has taken consent, if patient has come to you, you are also supposed to take consent. For example, in case of donor oocyte donor, form 13 is filled by ART bank also.
Correct.
And we have to receive 1 copy of form 13 from bank to confirm that whether they have taken consent of donor or not. But still, we are also supposed to take form 13 consent in our own clinic.
No.
Before oocyte retrieval.
No. Okay.
Before starting stimulation rather.
So that's a very important clarification that we have got from Dr. Geetendra. Dr. Nilesh, we'll just continue what rest all things one should do before the inspection starts.
Sir, one
Yeah,
doubt.
so
Sir, can I?
Dr. Kubera wants to ask sir something. Yes.
Sir, IUI is ART procedure, as you said earlier.
Yes.
If it is ART procedure, they can't do, if they stimulate and do IUI, it will become illegal unless it is registered.
Yes, yes. But if you are stimulating for timing of coitus, then it doesn't fall under ART Act.
Yes, sir.
No,
For
but
time
sir,
to intercourse, no problem. But for IUI, it will become illegal if they do.
Yes, yes.
Sir, I have a doubt, sir.
Gitendra sir, I just want one clarification that I am stimulating the patient for IUI. I have taken the consent form 7, form 8. I have filled up. I stimulate. I do my monitoring, and then whenever the patient is ready, I refer the patient to my colleague who is registered for level 1. Can I do that?
No, because you cannot take consent of form 7 and 8. You cannot use because you are not registered. So you have to register your place for that.
That means for giving gonadotropins for IUI, I need to register.
Yes, yes, yes. Because before stimulation, you are or you can do it in a different way. Suppose from a registered ART center, you can have a prescription from qualified gynecologist that please stimulate this patient with this stimulation protocol. Then according to that prescription, you can give medicine. Even nurse can give medicine in villages, depending upon that prescription. And they have to go for follicular study and they have to send the report to gynecologist for helping the treatment. So that can be done. But then you have to have prescription from some ART clinic which is registered. But if you are not registered, you cannot stimulate for that purpose.
For that purpose.
That is what my interpretation is.
So Dr. Chaitanya, so it's the indication of gonadotropins to be mentioned. That's the point which is important, what sir is trying to say, right? So,
Yes.
indication, if it is normal try, gonadotropins can be given by anybody and all gynecologists it can be given.
So that's what Dr. Rakhi was also trying to say, tell that if you're giving gonadotropins for IUI, then your clinic registered as level 1, otherwise you cannot give. Then as Gitendra sir has said, we can have a via media or a leeway if we want to go ahead with that kind. Okay, Nilesh, any other things what we have to keep ready at our end?
So we know the equipments which are required, no, the centrifuge, then the microscope and the refrigerator. So all this equipment should be there in place, and we should have a purchase list, purchase bills if the appropriate authority might ask. Then all the consent forms for the IUI should be ready. So we know that the starting ART treatment, all ART treatment, the form 6 is required. Then we have form 7 for the IUI by husband's email, and then we have form 8. So all this should be available with us, and they should be in place before the appropriate authority comes for inspection.
Right. So these authorities may ask for the purchase bills, as rightly said by Sir, that it is not mandatory by law that we should keep it. But this happened in my my case also. When they came for inspection, the doctor asked for all the purchases. I mean, my equipments are about 7-8 years old. So still I had to procure those bills from my CA. My entire thing goes back to the CA. So I had to procure them, and I have to show her the bills where I have taken the equipments from, instruments from, along with the serial numbers. So she even cross-checked the serial number which was put on the bill and against the serial number which was there on the equipment. So she went into that depth when she had come for inspection. So
again, sir, uniformity is not there in Gujarat. Wherever they have done inspection, they are also demanding different registration. So nursing home registration, whether it is there or not, even they are asking that whether do you have biomedical waste registration or not. So different registrations which are mandatory for a clinic, they are also demanding that registration licenses, means that whether you have or it or not.
Okay. Okay. The registration may be granted or rejected with reason in writing after giving due opportunity for hearing. So it's not that they will just say that it's been rejected before giving. Yeah.
I have got a doubt over here. Do they ask for the fire license?
Again, madam, I said that uniformity is not there. So,
but it is not written in that ART law anywhere that the fire license has to be there, because for the fire license to be applied for the ART level 2 also is a very big headache. As according to that, there are many important formalities which are required to be fulfilled. They don't give easily. You have to have a double staircase and all the other equipment formalities which has to be there in place. Without that, they don't give.
Madam, if you don't have fire NOC, then you will not get nursing home registration.
Yes,
So
exactly.
nursing home registration is compulsory for any ART clinic. It is mentioned that whether you have nursing home registration or not. And one more thing, they have asked in our in application that do you have MTP registration? Now what happened in one of the clinic in Calcutta, when they went for inspection, they asked. So doctor said that I do not have MTP registration. I don't do MTP. And most of the clinics, corporate, including who has multiple chains of hospitals, they don't have MTP registration. They don't do MTP at all. So he denied registration. That as you do not have MTP registration, I deny you to give this. Then that was made the issue, and representation was done in national board, and ultimately the license was issued even without MTP registration. So
Sir,
these
but
are
nursing home registration is not required ideally.
No, it is mandatory, madam.
Though it is mandatory, but any ART level 2 will not have a nursing home setup. Nursing home will again call in for the ICU, will call in all the other problems coming in for the ART 2 also.
Madam, nursing home registration is mandatory first of all. And in many of the hospitals, like particularly in Delhi and near Delhi, they say that no registration. Even in Haryana also, they say that less than 50 bedded hospital should not be registered under Clinical Establishment Act, which is new act implemented in Haryana. So, but still, you have to take one-time registration, because that is necessary. Nursing home registration, without nursing home registration, you cannot work. You can take daycare nursing home registration or whatever different types of registrations are available in your city. But nursing home registration is mandatory for any clinic to run, whether it is ART clinic, whether it is any other clinic.
Okay. So, Dr. Gayatri, what is the validity of this registration? For how many years it is valid once you take? Dr. Lata wanted to ask a question. I think she had raised her hand.
Sir, I've already put in the message. I said fire safety is mandatory for any hospital, any building where public gather, whether it's a cinema hall or whether shop, hotel, everything. So
Yeah.
whether it is a small clinic or not. That's what I wanted to say.
Yes, yes. We also have got clinical establishment certificate. In that, they ask for biomedical waste, pollution, and the fire safety, everything. And we have to renew it in time to time, once in 2 years. And they are asking for this clinical establishment certificate during their inspection.
Madam, in UP where Dr. Rakhi is working, there the registration is to be renewed every year. Nurse Clinical Establishment Act. And they apply every April and they get registration in next February. And immediately they have to apply for renewal. After
It is like that only over here. And the second thing is they don't give fire safety registration over here at all. And it is like this, that less than 5 beds, you don't require fire NOC for your clinic. And above 5 beds, you require, it comes under the Nursing Home Act. Other than that, less than 5 beds or 5 up to 5 beds, it is different story altogether.
Yes, madam, for that, every municipality and government has different laws. Somewhere it is mentioned that if your building is below 9 meters, no fire safety is required. So that kind of different rules and regulations.
15 meters is the thing which is
somewhere
taken.
it is 9 meters, somewhere it is 15 meters. So it depends. So that is okay. But even in your internal nursing home, you have to keep the sprinklers and the cylinders ready for fire as a fire extinguisher, and you have to get the fire NOC even from private entities.
So in Maharashtra, it is like it's a special building. So hospital building comes under special building. So any special building, irrespective of the height, should have a fire safety.
Even your doors should have a different type of color, which is fireproof color on the doors. So sometimes it disturbs your interior.
What is the validity of the registration, Dr. Gayatri?
So the registration is valid for only 5 years. And once you get the registration certificate, we have to display it in a obvious place where everyone can see it. And after 5 years, again, we have to apply for renewal, sir. And again, for the application, and we have to again pay that amount of
It's not
money.
only the renewal fees that we have to pay, we have to apply again, we have to fill up the application form, submit it. So probably there will be another inspection. Sir, what about inspection? When it goes for renewal, do they come again back for inspection, or it's just the information which we submit, on the basis of that they will be giving us the renewal?
Sir, there are many loopholes in the Act. So particularly in ART Act, many things which are there in PCPNT. Suppose change of staff, change of employee, what to do, change of name, what to do, change of category, what to do. So these are things which are not clear. Intimation of changes regarding change of equipment, change of employee, change of place, what should be done. So even on whenever it is renewal is applied, then again definitely inspection will be done again.
Okay. Okay. So we are discussing about the different definitions, as Gitendra sir has also said. So let's go through these definitions so everyone would be on the same page again. So what is the definition of assisted reproductive technology by law? Dr. Hemlata?
Assisted reproductive technology means all the techniques that attempt to obtain a pregnancy by handling the sperm or the oocyte outside the human body and transferring the gamete or the embryo into the reproductive system of a woman. This is the definition by law.
Gitendra sir was saying that you have to handle the sperm or the oocyte outside the human body, and if you are doing that, then only you need a registration for either level 1 or level 2, depending upon to what extent you are handling that those gametes. So
sir, not only handling, after handling you have to transfer it to reproductive tract. Then it becomes this. Only semen analysis does not come in ART.
That is a question which I have put at as an FAQ. Can a pathologist do a semen analysis without registering himself or herself for a level 1 ART clinic? We know that they cannot process it, because then they have to transfer the sperms to other clinic, which is not allowed without national board. So that's not done for sure. But what about semen analysis? Can a pathology lab do a semen? That was a question which I was going to ask you in FAQs. But since it has come now, we can just go ahead and answer that. So they can do a semen analysis.
Yes, yes.
They cannot do processing of the semen
Yeah.
sample. What is the definition of assisted reproductive technology clinic, Dr. Uma? Dr. Uma was there. Okay, anyone, any other person can take. Uma, yeah, Dr. Uma is here. I don't know.
Yes, sir. I am here, sir.
Yes.
Yes, sir.
No, what is the
Yes,
definition?
assisted reproductive technology clinic. It means any premises that is equipped with facilities and medical practitioners that they are registered with the NMC for carrying out the procedures related to assisted reproductive technology.
Okay, so means any premises equipped with requisite facilities and medical practitioners registered with the National Medical Commission for carrying out the procedure, the assisted reproductive. Perfect. What is the definition of commissioning couple, Dr. Kubera?
Kubera, unmute. Kubera, unmute.
Yes, sir. Can you hear me? It is infertile married couple who approach the assisted reproductive technology clinic or bank for obtaining the services authorized of said clinic or bank.
So it means an infertile married couple who approach an assisted reproductive technology clinic
Yes, sir.
or bank for obtaining the services authorized of the said clinic or the bank. Now this comes to a definition of what is infertility as well, and who all can have that. So what is the definition of a woman who can avail the assisted reproductive technology? Nilesh? So can we have 10 minutes more, Dr. Aki?
Yeah, I think this is an important topic. Let's finish it thoroughly.
So, Dr. Nilesh, what is a definition of woman by law? Who all can avail the services? I think Nilesh is not there. Okay, so any woman above the age of 21 years and who is less than 50 years of age who approaches an assisted reproductive technology clinic or assisted reproductive technology bank for obtaining the authorized services of the clinic or bank is termed as woman. So Gitendra sir, I would like to ask you, that means a single woman can go ahead and avail the services of assisted reproductive technology, but there is no definition of a man, single man. So a single man cannot avail the services of an assisted reproductive technology clinic. Is that so? Gitendra sir?
Yes, yes, sir. Sorry. So basically, single woman can go for treatment, any treatment. So if you will not treat a woman, then that woman can have a sex with anybody and can become pregnant. So you cannot restrict any woman to be pregnant. And second, no man can become father unless it takes help of surrogacy. So surrogacy is not allowed now for single men. So that's why a single man cannot procreate, but single woman can definitely take any kind of ART treatment for procreation. She can undergo IUI, she can undergo ODXC also, she can do donor sperm and OD means embryo donation also for becoming pregnant. So,
but
any treatment can be
her own. The uterus has to be her own. If she
yes,
goes,
yes.
Okay. Okay, that's fair. Explained. What is the definition of infertility, Dr. Minu?
Yeah, so any couple who is not able to get pregnant or conceive after one complete year of unprotected intercourse, that is said to be an infertile couple and can take the help of an ART specialist.
Right. What counseling of a commissioning couple is mandatory as per the ART Act 2021? If Nilesh is not there, Dr. Minu, can you take this?
Hello.
Are you there? Yeah. Okay. So what counseling should be done? It's very important to know what counseling has to go in before the couple starts with the ART procedure, any ART procedure for that matter.
I think the transparency is very important when we start the procedure, and the counseling begins with that. So all the transparently you should tell about the success rates of your clinic. So it will differ from clinic to clinic.
Correct.
And you should tell the overall success rate, the procedure which is to be done. You know, most of the times the patient is unaware of the procedure, the common side effects of the procedure, and
Correct.
what precautions we are going to take to prevent those side effects. So probably ART level 1 clinic doesn't expect OHSS to be occurring. But some odd case, if you're using gonadotropin, OHSS can be a remote possibility. So that even that remote possibility and common complications should be told to the patient. And probably we at our clinic we have a camera recording. So we have a camera also, and the first counseling or the consent counseling where the consents are signed. That counseling usually is done in camera recording so that you have a proof and that is stored with us. So that is how we go about it.
So in nutshell, everything that is needed for a couple to come to an informed decision should be discussed with the couple, which will help them to take a decision
Yes.
in whatever way they want to take it. Right.
Yeah.
Okay. Then
Jitendra sir wants to say something.
Yes, sir.
Sir, basically, whenever the word counseling comes, under ART, there are three kinds of counseling we should do. One is medical counseling. Second is financial counseling, because most of the problems arise from the finances. Okay.
Yes, sir.
आपने ये कहा था, ये नहीं कहा था.
That's right.
According to new Clinical Establishment Act and Consumer Protection Act, both the financial counseling is must. And third is psychological counseling. So psychologist is compulsory in now ART clinic level 2. So psychological counseling is also to be done. And whenever the word medical counseling comes, 6 things which are the part of every consent. Consent is nothing but the documentation of counseling. So 6 things should come. That what is the purpose of treatment, why you are doing this treatment. Second, what are the success rate or failure rates, as Dr. Nilesh has mentioned. Third, what procedures you will do. So you have to explain it in brief, that what type of procedures you will do on the patient in that case. Fourth, what are the alternatives available? And in alternative, it is your duty to inform patient even up to adoption. Adoption is also alternative. You have to also explain the patient the rights of child born out of IVF, and then risks of the procedure and risk of not undergoing procedure. So these are the 6 things which should be included in every counseling.
Okay. Okay.
So mainly rights of child should be explained after birth.
Perfect. Do not perform any treatment or procedure with the written informed consent of all the parties seeking assisted reproductive technologies. And consent may be withdrawn at any point of time before the gamete transfer. This is very important. So even if we have gone into onto the last day and they say that I withdraw my consent, even if all the efforts have gone into, you have to stop there if the couple says no on that particular day. Correct, sir?
Sir, definitely. But the problem is that the consent of ART Act, ART rules are not sufficient to cover. See, if you go through the consents, suppose you are doing self-ICSI, in the case where you are using for making embryo self-gametes, self-oocyte and self-sperm. But so previously in 2010 guideline, there was Form I was available for that. And in Form I, there were options to be tick marked that how you are going to form embryo, whether with self-sperm or self-oocyte, donor oocyte or self-sperm, whatever combination you are going to use it. But now in new ART Act, there is no such consent in which there is specific mention that how will you prepare embryo. That is the problem. So that's why we always advise our doctor friends that you should take new consents also, ART Act, but the consents which are not sufficient, you should take over and above that extra consents. So suppose you are doing embryo transfer, then you should take procedural consent of embryo transfer also, which will be according to Supreme Court guideline. Suppose you are doing ovum pickup, then over and above Form 12, you should also take a procedural consent of oocyte retrieval also. Over and above, if you are doing self-ICSI or OD-ICSI or ED-ICSI, so for making embryo, you should continue taking consent in Form I, which was there in ICMR guideline 2010, because there it is clearly mentioned that how you will prepare embryo, and that is the crux of the consent.
Okay, okay, that's a very important point which as sir has brought up. Okay, so coming to that, what are the different consent forms used in the ART clinic level 1? Dr. Minu.
So, as we've just spoken that in level 1, we are concerned with doing IUI. So Form 7 is pertaining to IUI when we are using the husband sperm. Form 8 is with donor IUI cycles. Form 10 is whenever sperm freezing would be done. And Form 11, which is a very important form, which talks on the assent of freezing of the sperm and parental consent. Now here, if you look at Form 11, there are 2-3 things that they've added up, which was not there earlier. That here they've also spoken that if the onus is on the patients also, if they do not come back to the clinic and do not give the consent over 10 years, then the clinic also has a right to either discard it or destroy it. So this is something we used to take it earlier. There was an extra consent that we had to add. This is in this, it has already been added. That is very good.
Then
And
there was communication which we had to send a mail and then get a
yes, there were earlier discrepancies now, but this here with this particular consent, this is an added good thing that is there. Second, here we do a lot of onco patients here in Delhi. So this is where it helped us that because with onco patients, the legal, the parental guidelines have come into place that who takes care of the sperm later on, because 10 years is a long period of time for any different kind of onco treatments which were going on. And I remember we used to really the whole counseling used to be on a very different level because we didn't know, and then we used to go back to the oncologist to ask about what is the survival rate of this particular cancer, what are you looking at. So this is very important, that who takes the onus, the parents bar the legal guardian. So that's another thing which is added here.
This is a very
this is Form 11. Yeah.
Jitendra sir, you want to add something?
No, not add, sir, but I want to ask Dr. Minu, madam. She is also LLB, I think. She has completed LLB, I think. So I will like, I will like to ask her that Form 6 is there to be signed by every couple who is undergoing any ART procedure. Okay. So that is Form 6. So should we take Form 6 over and above 7 and 8? Whether do you recommend that or not?
So for IUI?
Yeah, IUI is also ART procedure, no?
Yeah.
So should we take Form 6 also from commissioning couple or not?
Sir, I think with this new law, we definitely should be adding this because it's better to be safer than sorry, because as you said, there's so much of discrepancy and anybody can ask you at a later stage. We'll not be able to procure it. So my take would be to take an extra consent.
And one more
Won't
question,
harm.
madam. As you have shown this Form 11 that is on screen.
Yeah.
In Form 11, it is mentioned that in case of event of child's death, there is mentioned that to be handed over to my legal guardian. Now, how legal guardian will be able to use that sperm? Is there any provision under ART Act where legal guardian can use sperm of the child who is already dead?
Sir, but then there is a loophole here where they would have to go to the court with this form that they were given a permission while the child was alive to take care of the sperm. Now then, this is something,
That is okay. But suppose child dies, there are multiple such questions which had come in past. And there was a very nice answer in 2005 guideline in section 3.9.1.1 regarding sperm of a minor child. But previously, in a few cases, the government had allowed to use these sperms for procreation in a surrogate. But now surrogacy cannot be allowed without parents, without commissioning couple. So this sperm will be useless for legal guardian. So why they will take the charge of this sperm? What is the need of writing this in this consent?
Only wife, if she is there, or vice versa. Yeah.
Yes.
Then it would be of in any sense.
Yes, yes. For
Yeah.
guardian, it is no sense.
Yeah, yeah.
Okay, right. So moving on, what are the eligibility criteria for the clinic to determine eligibility of commissioning couple or a woman? Dr. Gayatri?
So, the age mainly, sir, because for the women and men it is different, and for the woman it is between 21 years to 50 years, and for the male it is 21 to 55, and it is always better that we ask for a age proof copy.
So it's not mandatory or it's not written in the law that you should have a age proof with you, but it's suggested or it's better if you keep a, copy of age proof with you at your end. Perfect. So
Sir,
what is
it is mentioned in the act that you have to take proof. The reason is it is not directly mentioned, but it is clearly mentioned that this act is to be interpreted by the procedural acts available. So in Indian Evidence Act, it is mentioned in section 100 that whenever you do something, okay, so the burden of proof in the court of law to protect yourself is on your head. So if you are treating any person who is below 21 years, and if you have not asked for the age proof, you will be in problem in the court of law. So it is always, you should always take, confirm the age in between 21 to 50. And moreover that, even if it is possible, you should apply your mind to confirm that whether the couple is married or not. Because you cannot treat live-in couple nowadays under ART Act. It is not allowed. So marriage proof is also to be demanded because registration of marriage is compulsory now in India. So if somebody do not have any marriage proof, then at least go through the Aadhaar card and read the name of the husband in that Aadhaar card so that we can confirm that they are a married couple. And it is not a, it is always a good thing to do that if no record is available, at least take an affidavit from the patient that we are a married couple. To protect yourself. Yeah.
Okay. So what is prohibited by the ART Act for level 1? Dr. Hemlata?
A woman shall not be treated with sperm derived from more than one man during any one treatment cycle. And the second thing is clinic shall not never mix semen from two individuals at one point of time. Then unused gametes shall be preserved for use on the same recipient and shall not be used for any other couple or woman. The sale, transfer, or use of gametes, zygotes, and embryos within or outside India shall be prohibited. Any sample movement from one clinic to other should happen with the permission of the national board. So the bank shall obtain semen from males between 21 and 55 years of age, both inclusive. That means 21 years old and 55 years old.
All the
that
points
are
are
inclusive.
very self-explanatory, and this is the point. Any sample movement from one clinic to the other should happen with the permission of the national board. That is where it comes that the pathology labs where we use in the past used to get the semen samples processed from the pathology lab, and we used to do the IOI in our clinic. That is not allowed. That is prohibited by the ART 2021, and we should not be doing these things. Okay, what are the information management requirements for ART level 1? Dr. Uma?
Yes, sir. Yes, sir. Regarding the information management, we should keep the records. The records should be maintained for at least 10 years.
10 years.
Or if, yes, 10 years. Or in case of closure of the clinic, we should transfer the records to the central database. And if there is a criminal or other proceeding in any case, those records to be preserved till the proceeding is till the end of the proceeding.
Closure of the proceedings or disposal of the proceeding. Okay.
Yes, yes.
And
And
there is
regarding other information, confidentiality to be maintained of the donor should be maintained, and the disclosure of information about the treatment should be done to the database of National Registry or to the couple in case of any medical emergency. And after any procedure, a proper discharge summary with all the ART procedures should be given. And regarding the enrollment of, the clinic should have an enrollment of commissioning couples or women. What are the procedures we are carrying out, and the outcome of the procedures and complications should be maintained.
So all these things which we are going to maintain at our end, we have to disclose it to the National Registry database if and whenever needed, and it comes into place. That is a very important point. As you rightly said, record keeping has to be done for at least 10 years or the closure of the for the bank. And at the end of 10 years, all these registered should be submitted to the central database of the National Registry.
I have got a question doubt over here. That if suppose the patient has got a frozen embryos kept at one center and patient wants to transfer and get the FET done at the other center, how it has to be done?
Madam, it is now available on website now of National Board. They have come out with form number, see 6 to 15 are the consent form. Now they have come out with the form number 16 to 24. And in those forms, there are different affidavits and application, which the person who wants to transfer embryo from one clinic to another clinic should apply to National Board with the affidavit from the accepting clinic and the affidavit from the clinic which has possession of that embryo. And once they get the permission from National Board, they can transfer it easily from one clinic to another clinic. In multiple cases, National Board has already given permission to transfer embryo from one clinic to another clinic.
Okay. Thank you so much, sir. So how to handle the grievance of a patient if at all it is there? Dr. Kubera?
The team, even though it is legally not clearly specified about grievance cell and all, so the team who takes care of grievance management should form the cell. Then that grievance management should be displayed in a patient specific area, like complaint cell, details of the grievance management, and that form 5 should be available for grievance management. That is for making the complaint about the grievance cell, whether information regarding the patient, whether he himself is applying or on behalf of him legal representative is applying, or relative or family member or anonymous member and all. This is what form should be available, and it should be this easily.
I wanted to ask you here that when we say that there has to be a team or there has to be a cell which contains members, now should all these members be within the hospital, or it's good or better if we have one or two people who are from outside the hospital as a part of this grievance?
Sir, in law, it is not clear. Okay. So they have not given any format that how to make grievance cell. As it is mentioned in, Vishaka committee or internal conduct committee, they have clearly mentioned that one independent social worker, female, who is female, should be the member of that committee. So in that way, there is no specification in this grievance cell. So it is better to make a grievance cell from your internal department only.
Okay. Thank you, sir. What are the offenses and penalties under the ART Act 2021? Dr.
Yeah, so there is absolutely no to an advertisement for any kind of sex selection technique, and sale of human gametes or import and export of human gametes is not allowed, absolutely. And in no ways any kind of exploitation to the commissioning couple, woman, or even the gamete donor is not allowed. And especially there has been a mention for selling or of the human gamete for any purchase of research. So that is also not allowed anyway.
Research purpose. Okay. For the purpose of research.
For purpose of research, yeah.
Health check. Okay.
And abandon and disown the child.
Someone is found doing advertisement for sex selective ART. What are the penalties for that? What's the penalty for that?
For
hello, for sex selective ART, what are the penalties? Jitendra sir,
yeah, sure. So basically, sir, again, there is discrepancy. You all know that under PCP, if you go through the PCPNDT Act, section 22 defines that if you advertise, then there is provision of up to 3 years imprisonment. But here in this act, they have mentioned that the imprisonment will be up to 5 years. So they have increased, but technically they have mentioned if the punishment up to 5 years imprisonment or fine or both, means or fine means only fine will be enough under ART Act. So that is again a loophole. And the thing I want to ask Dr. Meenu, that what do you mean by exploitation, madam? Exploiting commissioning couple or donor is a crime. But what do you mean by exploitation? Suppose I have explained 1 lakh rupees as a package and I take 1,05,000. Will it amount to exploitation?
Sir, that is also will be dependent on what the patient feels. If the patient feels exploited and she complains, then you have to justify whether you have exploited or not. Is what I understood after reading this, because it's such a gray area, the exploitation.
Yeah. So it will be on the discretion of judges,
Yes,
no?
yes.
Or authorities.
So we'll just quickly go through 4 or 5 FAQs. I want all my panelists to answer what they feel about the question, and at the end, Gitendra sir will tell what he has to say on that. So, can a gynecologist do stimulation without registering for ART level 1 or level 2 stimulation? Just look at the question.
Yes, sir.
Stimulation
do.
can be done as sir has mentioned.
Registering for ART. The catch point is for ART. The moment ART comes is absolutely no, you cannot, you have to register yourself. So.
Right. So if you're doing it for ART, that is for IUI or any other ART procedures, you cannot stimulate it without registering.
ART.
Register. Yes, Hemlata madam.
But for timing,
for ART, you have to register, sir. That's absolutely true.
Timed intercourse stimulation with even with gonadotropins, you can do or more than that.
त्याचा लॉ काढलाय
Can pathology labs process semen sample and send to gynecologist ART level 1 clinic?
No. No, sir. No.
No, absolutely no.
No. According to the ART law, no.
Okay. Okay. No transfer of gametes permitted except in the case of transfer of own gametes for personal use with the permission of national board. Can a couple woman get a friend, relative, self-donor to donate semen sample for them? And
yes,
yes, but they have to be routed. They can't get to the hospital directly. They need to register the known person as a donor through the registered bank.
So they have to refer that person to the ART bank, and the ART bank will follow its own procedure as laid down in the law, and then only you can take that semen sample and use it for the commissioning couple. Am I right, Gitendra sir?
Yes, perfect. Yes, so we have to channelize the patient through ART bank. Donor is always through ART bank.
Sir, majority of the times it is anonymous, no? Donor.
It was. Now it was, but now the law us to use even known donor.
Sir, previously in 2005 and 10 guideline, it was mentioned that donor should always be anonymous. Correct. But now absolutely it is otherwise, because the reason is that no oocyte donor will donate any person without taking a single paisa. Why she will take 10 days injection, then undergo anesthesia, undergo operative procedure for someone for donating purpose. So it is impossible now, and that's why only your friend or relative will go for you and will bear this pain for you. And that's why anonymity is now nowhere in the act.
It
can be anonymous also, no?
Yes,
Yes, it can be anonymous, but it is not mandatory to be anonymous.
Okay. Okay. Can ART level 1 clinic stimulate patient and send it to level 2 clinic for OM pickup?
Yes.
Yes.
They can.
Okay. All of you are saying yes. Fine.
Yes.
So, we will take.
I answer it in negative.
Okay.
Yeah. The reason is ART clinic, which is only registered for IUI. Okay. That cannot take consent of ART clinic level 2. They don't have consent of 9 and 12 and all other forms. Form 6, 9, 12, they are not with them. So they don't have consent for ART, this OPU. And that's why ART clinic can definitely stimulate, but only with the prescription from a doctor who is working in ART level 2 clinic. That is my understanding.
As you said, for IUI.
Yes.
Now, one doubt for me, if
Yes,
they are stimulating it for IUI, and if the patient develops more than one follicle.
So you have to document the counseling, and you can definitely shift that patient to ART clinic.
Yes.
But the ART clinic level 2. But you cannot do it as a practice.
Yes. Thank you.
Where to submit the offline form? I mean, it's with the local authority, I suppose, and that's different for different states, even within the as well. So we have to authority, if I am correct. So I think we have come to a end of a very nice discussion. What should be done, what should not be done when you are having a level 1 ART clinic register, and what all things we need to get ourselves registered for the ART1. This is a small and humble request from my side to all of you. Please vote and support me in my endeavor as the chairperson for the endocrinology committee. The voting would be between 16th and 25th of August. Thank you so much. Thank you so much.
Sir, if you allow, I will also
Thank you
like
so
to
much.
do an announcement.
Yes, sir. Please.
Sir, we are having one 3 days West Zone VP conference at Ahmedabad on 4th, 5th, and 6th August. And in that conference, one day we will be having 8 workshops on 4th. And on 5th and 6th, I would like to inform everybody that there will be 2 halls continuously working. In one hall, there will be 2 days National Medico Legal Conference. So everything related to medico legal will be discussed. And in another hall, continuously obstetric and gynec topics will be discussed. So you will get opportunity to learn obstetric, gynec as well as medico legal in whatever field you have. And the registration charge is nominal. See, in most of the conferences where it is a 3-day conference, nobody takes less than 15,000 or 20,000 as a registration charge. But in our conference, we are only we have put 6,500 rupees a registration charge for 3 days conference. So that is a very good opportunity, and I will like to invite each and everybody to Ahmedabad. And I assure you that you will get the best out of your 3 days learning. Thank you. Thank you very much, sir.
Thank you.
So much, sir.
Thank you, sir. We're
Thank
looking
you, sir,
forward,
for
sir.
taking out your valuable time. And thanks to Chaitanya for doing a good job of roller coaster ride of
Who
ART.
suggested to have a panel discussion on this topic? Please prepare yourself with this topic. I said, fine, I will try my best.
Because this is a burning hot topic which is required for all of us to understand. And who else could do justice other than Gitendra Sharma, sir, for the opening of this series to be there with us. Thank you, sir.
Madam, I will like to put one remark, last remark.
Yes.
Yes.
See, you should not practice infertility if you do not know how to document. The reason is that in very near future, I can say within 1 month, you are going to get one judgment from National Commission, and the award of compensation in that case is in crores, more than 2 crore. And the case is only that the doctor who did IVF to a patient in 2009 without taking proper consent, and it was found that the baby is not matching the genetic material of mother and father. So he used donor sperm without taking proper consent, and patient has filed a case against doctor that this amounts to mental torture for me for whole life. I cannot accept this child as mine for whole life, and for that more than 2 crore compensation is going to be granted in future. So dear friends, even you have practiced for last 10 years, if you don't have records, that can create problem for you. So at least from today onwards, if you don't know how to document, stop doing practice and learn first how to document, what different consents are necessary. Only then you should practice. So sorry to say, but this is my experience I am going through nowadays, and multiple cases are now filed against doctor. So 10 saal pehle, if you have done something wrong, today you are going to be punished. and that is the serious thing. So from today onwards, at least we should be careful. So thank you very much for inviting me.
Thank
This
you, sir.
panel.
And for any more help, if you need, Gitendra sir is always there. So
Definitely.
please take help of him whenever needed.
Yeah.
Sir, you yourself can tell where to download all these centers for the newcomers and for the other gynecologists who are not practicing, who have started just now. All the consent forms.
See, madam, it is available, everything is available online, but we should know that what kind of forms are to be filled in which procedure. So suppose you are doing self-ICSI, then you are supposed to take consent in form 6, 9, 12 and form I.
Yes, we have been downloading it from those days, ICMR forms. Any new forms have come, sir? Any new website?
No, these are enough. But over and above this, we should take extra consents because certain consents are not complete consents. And that's why we advise that even in 2010 guideline form I was there. You should continue taking that. In case of TISA, PISA, there is no new consent in this new ART app. So you should continue taking TISA consent in form H, which was available in 2010 guideline.
Yes.
For embryo transfer, there is no consent in this ART rule. So that's why you should continue taking embryo transfer consent, which we were taking in 2010 guidelines, at least to save ourselves.
Thank you, sir.
Okay.
Thank you,
sir.
Dr.
Thank you
Raki.
so
Thank
much,
Dr.
sir.
Chaitanya. Yeah.
Thank you, Dr. Chanda madam. Thank you, Dr. Lata madam. Thank you all my panelists, Sampath Kumari madam, Rishikesh Pai sir, for giving us this opportunity. Dr. Raki, you would like to conclude it?
No, you can do it.
And thank you, Gitendra sir, for being there and for being there at any point of time, to be honest. Thank you so much. Thank you, the presidents of all the societies who participated today, for giving us this opportunity. We will be continuing with this series. We are going to have this every 15 days with 5 to 6 different societies from within the country. Thank you so much. And I would like to thank Corona Remedies also. They have been
Thank you so much, sir. Thank you.
for this
Thank you.
webinar and other webinars which we are going to have in future as well. Thank you.
Thank you so much.
Thank you, all the esteemed faculty, for taking out your valuable time for being there for the endocrine committee of FOXI. And thank you, sir and madam.
Thank you, sir. Bye. Thanks, Dr. Chaitanya, Dr. Raki.
Bye-bye. I'm ending the session.
Yeah.